wonderful session. We know the minimally invasive endoscopic spine course from ASICON. We really appreciate all of you joining here today. So let me go through the overview. We have an excellent faculty with me today, which will sort of guide you through how to start your endoscopy journey. So the very idea of this was to, we wanted to not waste much time during the cadaveric labs. So this was planned way ahead. If the whole concept was to go through all the talks, whichever is possible beforehand, so you get a orientation, you get an idea, and so that when you go for the cadaveric lab, it's all about hands-on. We wanted to give you maximum hands-on experience, and that is how the course was designed. From the very beginning of the course, it was a two-part session, and that is how it was advertised, and that how it was promoted. So, even for those who, for whatever reason, they could not join today, we are making a recording, and hopefully we'll share with you. But the idea was for everyone to join, not only that so that you can listen to the lectures, but the most important is to clear your doubts, because this is the best way to clear your doubts. Once you have the deep understanding of the process, of the pathology, of the anatomy, I believe that is the time you can go and really sort of benefit from the cadaveric lab. Me and Sambhav, we are the conveners. Sambhav, anything you want to add?
I think you've added most of it. I think this is everyone should try and get the most of it, and also this is going to it's the first part of our workshop. So whatever you learn here, we try and incorporate how much of whatever you learn here into the workshop meet on the day of the cadaver. And in between, if there are any questions, Ayush and me are available. We have a common group. All of you guys are there on the group. So please feel free to ask any questions you have, and we'll be happy to answer all your queries.
Okay. So the how we'll go about it, we'll ask you to keep yourself muted when the talk is happening. Once the talks are over, we'll give you enough time to ask your questions. Even for some reason we cannot take the question right now, you are most welcome to put it on the delegates group. We'll make sure that faculty sort of answers each and everything. To start the beginning, we have our opener batsman. No one can be as good as Dr. Pradeep Singh. He's a good friend and colleague. And anything you start, the understanding of the anatomy is the paramount. You cannot do it without having a deep understanding of the anatomy and the pathoanatomy. And the most common thing which no matter who you are, no matter how big a spine surgeon you are, it is the back pain, which is the most common problem, and this is what is your bread and butter. So, what Pradeep will talk about today is the pathoanatomy and how endoscopy could be a solution in disc back pain coming from disc pathology. Over to you, Pradeep.
Thank you, Ayush. Yeah. Hi, good morning, everyone. Let me share the slide. So, it's visible.
It's visual, Pradeep.
Right. So I'll be speaking mostly about pathophysiology and then pathoanatomy, surgical anatomy, and mostly pathophysiology, which is related to the interlaminar and transforaminal endoscopy. So I would be speaking mostly on the pain generators. So if you see this, there's so many neural supply to the annulus fibrosus, which is the most commonly, the pain generator pathology in annular fissure. So if you're treating disc alone, not addressing the annular tear part or the annular fissure part, then back pain obviously would not go completely. Surgical anatomy also I'll cover. There would be a lot of slides which would be overlapping. Dr. Tarun also would speak on this, but I will cover mostly the pathophysiology pain generator part out of it. So pain generator first. So we have annular pain, as I said, annular fissure or annular tear, we call it. Annular tear is the connotation given mostly to if the pathology is traumatic related. If it is trauma, then annular tear is word used. Otherwise, annular fissure is the right word. Posterior longitudinal ligament inflammatory process. So there are a lot of cytokines released whenever the disc slips backward and hits the PLR or annulus fibrosis. So that gives rise to the pain. Facetal pain is also there because of the disc or because of the irritation of these nerves. So if you see this, uh, the annular nerve supply, which are coming from sinovertebral nerve, which is one of the, I'll cover that, which is one of the branch from the dorsal root ganglion, which goes there and, supplies this. And whenever the disc hits this part, the pain obviously would be radiating down and mostly to the gluteal area. So the pain generator, how we diagnose and how we match clinically with the MRI picture or real surgical scenario. So whenever the nucleus pulposus goes up till here, I hope you can see my cursor, it would be only back pain. Once it goes to mid substance, the pain would be usually radiating down upper gluteal part. Once it covers this thing, the 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 most neural part of the annulus fibrosis, the pain would be radiating mostly to the thigh. And once it hits the nerve and then it goes below the knee, that is classical sciatica. So this is one thing. Neurotization or neuronal sensitization and pathological innervation of disc is one of the common thing. So whenever we have chronic disc pathology, there would be new vascularization and the neurotization. There's new nerve formation. So whenever we try to touch, sometimes, in doing transforaminal endoscopy, and we try to, grab the disc with the forceps, and the patient winces or is extremely painful at times, and it's all because of the neural sensitization of that disc. Also, that disc become vascular eventually if it is chronic one. This was, I was talking about the discogenic pain could be due to the sinovertebral nerve, which would give you pain there in the PLL, I mean from the PLL or the annulus or the facet. Likewise, basivertebral nerve. And this is very important in chronic pathologies where the modic changes or chronic end plate changes there. And so microscopic anatomy, if you see, there would be neural development all along the pathology through the modic changes, and that could be the source of pain. In such cases, if you're addressing only disc, you're removing disc, the back pain would not go. Probably neural pain will go, but the back pain will still be there. So we have to do, if you're doing open or if you're doing transforaminal or interlaminar, so we have to do some thermal annular plasty, or these nerves should be blocked or should be cauterized. Interlaminar first. So interlaminar anatomy is all standard anatomy where I would just share some pictures, endoscopic pictures, which is the first what we see, the muscle and the fat layer. And then you need to clean this. And once you clean this, you would see a good whitish yellow phlegm. And then once you cut this, if you see this is epidural space, which shows the fine epidural fat. And once you extend this thing and once you go down, if the disc pathology is there, then the disc would be seen. And once you remove, you see all beautiful neural structure, which you don't appreciate much on transforaminal endoscopy. And the area you cover with one incision, you go up till the inferior part of the pedicle, which is superiorly migrated disc here, and the inferiorly migrated disc here, right? So you can cover a vast area, not only the discal area. Cambian's triangle, which will be, I think Dr. Tarun must be speaking on this. Triangle is very common, and this is the only area where we're going to work in transforaminal endoscopy. Anatomy wise, if you come from top to bottom like L1, L2, and L2, L3, L3, L4, the area becomes gradually wider. So you get more space at L4, 5. So that means chances of injuring exiting nerve or end plate or complication would be lesser on L4, 5 than L3, 4 or L2, 3. This is how endoscopically you see that, right? So this is important to, and this is an axial view where we are working, which is Camden's triangle. Extraforaminal anatomy, this is important once we do transforaminal scopy. So we have a lot of ligament coming from top to bottom. So whenever we try to put scope in and they come in the way, and you need to negotiate them. So that's why we advise, I mean, in literature, they advise that foraminoplasty or foraminoscopy should be done first to see, because the foramen is quite vascular area. If you see this foramen anatomy, there's so many arteries and veins. If you see CT angiography, you have a lot of arteries there. So you need to cauterize them. You need to do foraminal scopy first, and then go inside. We have wile ligament, and that is sometimes that is adhered to the nerve root, and that's why it's very important to understand anatomy of these ligaments. Vascular anatomy, I mean, this has very little practical significance in practice, which is all the supply to the dorsal root ganglion or the facet. There's 5 to 6 facetal vessels which comes directly from the abdominal aorta, lumbar or segmental artery. Then it goes to branches, goes to DRG and this thing. Important is artery of Edemkes, which is present around 5 to 6% of the patient. L5 is the supply of internal iliac artery, otherwise all coming from abdominal aorta. So whenever you bleed them, whenever you injure them, the gush of blood would be so high because it's directly coming from the aorta. So be aware about uh, location of these now arteries. This is very important. Ganglion, dorsal root ganglion. So if you come from L1, 2 or L2, 3 or so, the position of ganglion is quite foraminal. And once you go down, the position of ganglion goes inside, is mostly in the canal. So the reason why, I mean, so that means L4, L5 ganglion would be mostly in the canal. And whenever we have, so L4, L5 disc, which is mostly common site of disc, slight paracentral disc will produce greater intensity of pain. The reason could be the dorsal root ganglion is right inside the canal, and that disc is hitting actually the dorsal root ganglion. Right? So this is important, and this is important because this gives uh, come to that. This gives branch, which I was talking about, sinovertebral nerve, right? So sinovertebral nerve basically comes from here, and also it has fibers from the sympathetic chain, and this goes to PLL disc and the facet. So whenever we have slip disc, there's no chronic changes there in the so, and still pain, patient feels pain in the back. It's all because of the disc hitting dorsal root ganglion, sinovertebral nerve going to facet, and its facetal pain. So whenever you give block, diagnostic or therapeutic block, and you block this ganglion, the back pain also get better along with radicular pain. This is venous. We come across a lot of veins, and also these are the position. And why this is important historically, there was a term Vesper curse. That means whenever the patient in right heart failure, where the right side, the venous pressure is high, so obviously this would cause engorgement of these, the volume of these now would increase, and this would indirectly put pressure. So there's so many veins. This would pressure over the dorsal root ganglion and the nerve, and the patient would feel paresthesia, radicular pain in the patient who are having right heart failure or right side of the venous increased pressure. So venous anatomy is important not only for this, but But surgical bleeding is the major source. This venous, this thing is a major source of surgical bleeding at site, whatever you do interlaminar or transforaminal. This is important, which is the measurement of foraminal width. So we can divide into, this is however not validated classification, but we measure this from the base of the, uh, where this is taken from. They measure it from tip of this thing to the base of the pedicle and the superior facet here, this distance, and they classified as to mild, moderate, and severe. Rather, I would uh, prefer to measure the distance between the the vertebral body and the pedicle here down up till the tip of the facet, superior facet. And this is the distance where the exiting, this is the area where the exiting nerve root would be lying. So this pathology is important because we need to measure pre-op, because if you are doing any procedure interlaminar or transforaminal is very difficult to negotiate that scope through this small hole. And this is advanced disc disease where the foramen is quite narrow. This is due to the fact because of the supero-inferior stenosis is more common whenever the chronic pathology is there, because of the disc space is lost, and then supero-inferior stenosis would be there. And because of the ligamentar hypertrophy or the disc protrusion, the antero-posterior stenosis also uh, could be the pathology and the source of pain. This is very important thing, which is high. This is more relevant here for transforaminal, high iliac crest and low iliac crest. Why this is important? Because if you're operating L4-5 with a standard, this is normal iliac crest height, and this would go mostly horizontal. But if you try to go to L5-S1 with such thing, this would obviously, you have to go steep, and the exiting nerve is coming from here. This might kiss the exiting nerve root. What options we have? This is one of the, again, non-validated classification of high grade superior migration, which would go up till here. Low grade means it would maybe around here, and low grade is again low grade inferior migration here. High grade inferior migration would be quite down against the pedicle. Again, canal compromise, we call it mild, moderate, severe. It all depends on how much the canal is being compromised. Structural anatomy here is relevant once it comes to the facet. And once you make the trajectory and saving the nerve, this is axial view of Campbell's triangle. And once you put the scope line, you are quite away from pathology. If you go near the pathology, you have to start entry far lateral, and which would enclose the retroperitoneal space. So you have option of going medial, not lateral, but you'll be away from the pathology. So what you need to do, you need to push the scope down in order to reach here nearer to the pathology, or maybe alternatively the foraminoplasty is one option which Dr. Datar is expert on. You need to cut this, undercut the ventral surface of the superior facet, and you can easily then go down inside. Now, so we have percutaneous endoscopy solution for different pathology, right from cervical, thoracic, anterior, posterior. Lumbar is the most widely prevalent, and we are talking mostly here lumbar pathologies. So we have approaches like extraforaminal approach for the pathologies which are outside of the foramen, which is far lateral disc, and we have interlaminar approach for everything. We can approach every disc, paracentral, central, lateral, not far lateral, but lateral disc or foraminal disc also we can reshuffle. Transforaminal approach is the approach for the foraminal disc or the superior migrated or inferior migrated disc, paracentral or central disc. Now, these are some approach which when you're going inside the canal or when you're remaining outside the canal, if the disc is far lateral or foraminal, you don't need to go inside. Your uh, your pathology is right in front of you. Don't need to enter in the disc. Once the pathology is paracentral or superiorly migrated or central disc, then you have to go inside the canal. And if it is L5S1 for paracentral or any sort of pathology, interlaminar, I think, would be the procedure of choice than transforaminal. This is transforaminal endoscopic anatomy, which will be discussed in subsequent lectures. These are few cases. I'll just run through that. Not relevant here in this talk. So indications. This is important slide, So what are the cases where you should do transforaminal and what are the cases where you should do interlaminar? So in my view, interlaminar can be done for everything except far lateral, and transforaminal can be done for everything except absolutely central disc. All type of pathologies can be dealt with for the pain management, like central disc herniation predominantly with back pain, annular tear, which will cause chemical sciatica. So this you need to understand the pain generator, where the pain is coming from, and then you have to see the surgical anatomy and the anatomy of that particular patient, and you have to choose the the procedure, whether it would be transforaminal or the interlaminar. Yeah, thank you for the patient hearing.
So thank you, Pradeep. Before I venture into endoscopy, I never understood that there was so much anatomy to the pain generation. As a traditional surgeon, you don't read about it, and that is these talks are not to scare you about it, but you make you aware that these are something which, as a traditional surgeon, neither you understand, neither you read about. And when you venture into endoscopic, these are the things you should know about. Only if you know about them, you can treat them. Any question, anything from the delegates, you are most welcome to ask. Sambhav, coming to pain generators, do you I know endoscopy. Do you find them endoscopy to be a better approach, especially when you deal with these chronic pain generators in lumbar spine?
I mean, if you see theoretically for these pain generators, the transforaminal approach was developed. There was something called as disc effects initially, where we would use use a radio frequency in the annulus to reduce the discogenic pain. But I don't know how many of us are still practicing it. Especially in my practice, I at present am not using endoscopy just for discogenic back pains. But definitely, if there is and if you have to, I think endoscopy would be one of the better approaches to use, as it's minimally invasive and whatever the advantages Dr. Pradeep has pointed out. Definitely endoscopy would add up to all those advantages with regards to this discogenic back pains.
What about Dr. Dattar, your experience? Do you treat discogenic back pains with your endoscoping armamentarium, or you still believe they remain an enigma, they are just chronic back pains? You're muted, Dr. Dattar. Please unmute yourself. Yeah.
Yeah. Am I audible?
Yeah, now you are audible.
Okay. First and foremost thing, if there is a pain generation, there is a pathology. The only thing for us is to identify the pathology. That is going to be the first thing. So to identify the pathology, there are multiple things that can be performed, like discography. If you're looking at intradiscal generation of pain, if you're looking at pain from the foramen and from the lateral recess, then you should use a lateral rectal epidurogram, and a block, which will give you by and large a fair amount of idea from where the pathology or where the pain generation is. I do use endoscopy in all my patients with discogenic back pain who do not settle with routine line of management, that is exercise, weight loss, and other things. So endoscopy is a very good option for us to target these pain generators, and we are able to identify, even in fact visualize most of these pain generators endoscopically. So I do use it a lot in my practice.
Okay, so any questions you guys have, you are free to put in the chat, and let's move on to the next talk. Transfemoral anatomy is something different. As a traditional surgeon, I could never understand, or I even care to understand the transfemoral anatomy. But if you want to be endoscopy surgeon, this is a completely different ball game, and to do anything, you should understand the pathway to it. And to talk today about transfemoral anatomy, we have Dr. Tarun Chabra, who will talk about how to understand this anatomy and how to use it when you want to do a transfemoral endoscopy surgery. Over to you, Tarun.
Thank you, Dr. Ayush, for giving me this opportunity. And I am very privileged that Dr. Datar is also there. He is my mentor, and all stalwarts are present. I will be talking very basic of transforaminal anatomy for a beginner, where we start from open surgery and transit to the transforaminal endoscopy. So I am sharing my screen.
Make it full screen, Tarun. Yeah.
Yeah.
Yeah, now we can see you full screen. Go ahead.
So in my talk, I will be talking about 7 points, and I will be starting with one picture and ending with that picture. If that is fit in the mind, then you can do the endoscopy nicely and you will not have any problem. So I'll be talking about the boundaries and walls, structures which are in foramen, Camping's triangles, nerve supply, vascular supply, and foraminal ligaments, and endoscopic anatomy. That is the first thing that we will see when we land up in the disc. So this is the picture I want to emphasize everyone who are starting the endoscopy, because we will be seeing the anatomy from the lateral side, not from the midline. So everything in this picture is very, very important. The location of the DRJ, the exiting route, traversing route, and as we progress dorsal, we go for the dura and we find the ligamentum flavum, and we see the SAP also. For the stenosis cases, we can go for the SAP burring also, that I will be discussing. So first of all, when we enter in the foramen, the 3D anatomy of the foramen should be in the mind of a surgeon, and we will be progressing with the C-arm. So we should know the midline, and we should know the planes that we are working. The transverse plane of L4, L5 and L5, S1 should be there, and we should see in the lateral view what level of lordosis is there, and the plane of inclination is different for each disc level. The inclination plane of each target disc is drawn on the skin, as you can see from the lateral disc center to the posterior skin surface. Now the point is next is to measure the distance between the lateral disc center and the posterior skin surface plane is measured, and this is the disc inclination line. The most practical slide is this for the needle entry, where these lines transect. Then almost the distance is 12.5 centimeter. That is the safest distance in a study done in Indian patients. So we can traject at 25° to 30°, but that this anatomy can vary from patients to patients. So with experience, we can know the trajectory. In obese patient, we have to go more, the angles has to be increased. So this is a very good study done on the cadavers. So 96 foramens were studied. So the average triangular safe zone was 18.9 in width and 12.3 millimeter in height, and hypotenuse was 23 millimeter. So the conclusion was that 7.5 mm cannula placed in line with the medial 1/3 of the pedicle, that is very important, or 6.3 millimeter cannula located in the midline of the pedicle are safe. So the crux is that we have to work in the Cambin's triangle, that is our excursion zone. So while we do excursion, we should know that where is our park and what are the boundaries of our foramen. So the roof of the foramen is formed by the inferior vertebral notch of the pedicle of the superior vertebrae and ligamentum flavum at its outer edge. The floor is the superior vertebral notch of the pedicle of the inferior vertebrae and posterior superior margin of the inferior vertebral body. The anterior wall is the posterior aspect of the adjacent vertical body, disc, lateral expansion of the PLL, and anterior longitudinal venous sinus. The posterior wall is superior and inferior articular process of the facet joint at the same level as foramen and lateral prolongation of the part 2 of the ligamentum flavum. And the medial part is, medial wall is dural sleeve and lateral wall is a fascial sheath overlying the psoas muscle. So what are the structures when we enter in the foramen? We should be very careful. For a beginner, we should not go in the root area. Otherwise, the patient will wince in pain. So there are spinal nerves. They are combined ventral and dorsal root in the root sheath, dural root sleeve, which become continuous with the epineurum of the spinal nerve. There are a lot of lymphatic channels also, and as Dr. Pradeep told about the segmental artery, communicating veins, and there are sinovertebral nerves and adipose tissue surrounding the structures. This is the most important thing that tell us to do the transition from open surgery to the transforaminal technique. So the Cambin's triangle is anteriorly by the exiting root and inferiorly by the end plate of the lower lumbar segment and posteriorly by the superior articular process of the inferior vertebrae, medially by the transverse nerve root. So this is the triangle of excursion where we will land our needle entry into the disc and then we come out in the inside out technique. Lot of discussion has been done by Dr. Pradeep already on the spinal nerve and sinovertebral nerve. So the spinal nerve goes into posterior ramus and anterior ramus, and the sinovertebral nerve is from the anterior ramus, and skeletal branch and muscular branch also from the anterior ramus. So the vascular anatomy, the most important point of the vascular anatomy is that we should be cautious in the MRI if there are vascular malformations. That is the only point. Otherwise, we have to stop the bleeders. The two supplies, one is external, that is supplied by the lumbar segmental artery, and internal branch divides into 3 parts. And the one part of that branch will goes to the lamina ligamentum flavum posteriorly, and anterior branch goes to the posterior aspect of the vertebral body, and the neural branch courses to the spinal nerve and supplies ventral and dorsal nerve roots. So there are ligaments in the foramen. So sometimes we don't see the pathology in the MRI. So Dr. Gore emphasized this point that MRI is not 100%. Like when we go in the transforaminal technique, we can see the ligaments and we can free up the ligaments, and patient will have pain relief when we release these ligaments. And superiorly also, these ligaments protect the nerve, the exiting root. So this case is L5S1. I will land up inside the disc, and first of all, the transition from a open surgery to a transforaminal technique, we land in the disc, and inside the disc, we take out the disc material and come out. This is the first image that we will get, and take out the disc and do the intradiscal work. And we see the annulus part. So the cutting the annulus is very important because when we do a punch, we can injure the neural structures also. So we have to rotate our scope and we have to rotate the annular cutter so that we can have a proper visualization and we have a proper sound when it cuts. And patient is in local anesthesia, so we can have an idea that the nerve root is not injured. And once we have cut the annulus, then we have to sweep the floor. We have to make the rent complete so that no fragment is left. You have to go superiorly, inferiorly, and swipe over the floor. And the fragment should come out, and the patient will get benefit from this procedure. So this is the last image of my talk. This speaks everything. This anatomy should be there in the mind of a young budding surgeon, and he will have no problem. If anything happens, you again check the anatomy, that where are you, you see the C arm, you visualize in the scope, and then proceed. Thank you.
Thank you, Dr. Tarun. And so, how difficult or easy was for you to go from being an open surgeon into a endoscopy surgeon through a transforaminal approach? And what are your tips and tricks? How did you did it? Girish Datta did it many years back, and now he won't remember, but you will remember. That's why I brought you for this topic.
Actually, I did my transition from open surgery to transforaminal surgery after listening talk from Dr. Datar when he came to KEM Mumbai for a basic spine course. Then I had to tilt my head like this, like I am seeing from the back and then I'm seeing from the side. I could not understand. And first needle, I didn't understand the making of the lines. I pierced the DRJ and patient winced in pain. Then I thought, oh, this is a dangerous technique. I will not do this. I will do my open surgery. For 6 months, I didn't touch the needles. Then again, I did a cadaver course and emphasized on the lines, and then step by step. We cannot miss any step in this technique. And if you land properly, then the work is 90% done. The landing is important, where the inferior migration is there, paracentral disc is there. That after doing 30 cases, I was very much confident that this technique is wonderful, and I am not doing any open surgeries except trauma cases.
So for me, I think what made it easy was I was giving root blocks for a very long time. So those, at least personally, I feel if you want to venture into the transforaminal endoscopy, of course, understanding the anatomy and like understanding the pathophysiology is the paramount, but needling is the most important. And if you're used to, giving those blocks, the sort of needling naturally comes to you. You understand how to maneuver those needling. So I will suggest anyone who wants to venture into it, start with the root blocks. That is the simplest way to start. Sambhav, any tips and tricks for the
No,
beginners?
actually, I just have a question to even the faculty and even delegates can answer. Now, we have transforaminal and interlaminar. There was a time when people would start doing transforaminal and eventually venture into interlaminar. I started with interlaminar and then I ventured into transforaminal. So, from the faculty point of view, any tips for our delegates who are going to start the endoscopic journey? What would you tell them? Should they start transforaminal? Should they start interlaminar? Should they start both at the same time? So just your views on for the delegates, because that is one question which I'm
Let's
asked a
start with
lot.
Dr. Datar. What will you tell them? You do both, you are master of both. So where will you ask them to start?
Well, it's difficult because, as an open surgeon, we are all very well versed with the anatomy that we see from the posterior aspect. But I'll tell you one thing, it is not just the anatomy, but it is also the handling of the scope and the instruments, which is a real important thing for which one needs to get used to. I would always suggest everyone to start with transforaminal surgery, because if you just adhere to the principles of the surgery, you're by and large able to do the surgery. So develop the skill required to handle the endoscope and the various instruments, and then it is very easy for you to transition into interlaminar surgery. I would suggest it would be transforaminal to start off.
Pradeep, what about you?
I'll go with Dr. Dakar. I think since we are we are used to of doing posterior surgery, if we could do simultaneously things, and that would be easier. I mean, no need to go one by one. I think do everything one together. Yes, but root blocks first and then transforaminal. Open first and then interlaminar. Yes.
Okay, I think to make things easy, I will next talk about how to choose what, when you should, go into transformal approach, when to do the interlaminar approach. For me, I did the other way around. I started with interlaminar because I was very good with tubes, so that is where I was. I could understand the interlaminar anatomy very well, but once I could handle the scope and everything, that is the time I went into transforaminal. And as I told you, because we have been giving blocks for a very, very long time, it was just a stepping stone. But that is where you are. I think it is also has to do with where you are starting from, what you are confident with, and of course, it is bit individual. So thank you everyone and welcome. My job is to uh, talk about when to choose what, when you should do a transferal approach, when to do interlaminar approach. Thanks to my colleagues, they have already talked about the anatomy and everything. So as I was talking about, if you look at the interlaminar, it is a familiar approach. As Dr. Pradeep was telling, except for maybe one or two odd cases, if you can learn and master the interlaminar approach, like some of the stalwarts, like Dr. Lokhande, Dr. Datar, then everything, almost every pathology could be tackled interlaminary. So much so now they have started, people have started doing fusion surgeries as well. It is a familiar anatomy because no matter who you are, whether you're open guy or a tubular guy, you are familiar with the anatomy. It's a versatile approach. You can do everything. But the patient selection is paramount and understanding the anatomy is paramount. If you're doing an interlaminar approach down below, for example, at L5S1, you have a lot of space. You can really have a lot of space means there is a lot of and not that lot there's a lot of room for your pathology to be there, your anatomy to be there, and your scope to be there. But as you go up, the space becomes crumbled, and that is where you need to be slightly careful. Now, something like this, extruded lateral disc at L4-5, L5S1, the interlaminar approach is the easiest and the best thing you can do because all you need to do is to make sure that your roots are free. If you're, for example, this is a 5S1, there is extruded disc, it is just sitting below the 5S1, and all I need to do is to make sure that I take out the disc which is just sitting down, and at the end of it, I have to make sure that this is the disc which comes out. You have to make sure my root is free, it is mobile, and that is the end of the surgery. So if you're starting your journey with interlaminar, I'll suggest you choose something like this. Again, for something like this, which is a big, huge migrated disc, like this is for the L5S1, the interlaminar approach sort of gives you a lot of room. The transfemoral approach, if you see, you're bounded by the anatomy of the foramen. Of course, you can maneuver a bit, but it is not as maneuverable as something like some as the interlaminar approach. So if you see this case, this is AL5S1 superior migrated disc, which is covering almost the complete of the foramen. And this patient comes to with a foot drop. This is how she is walking. There's a complete foot drop because the L5 root is being crushed because superior migrated disc. This is just to demonstrate how much you can reach from the base of the disc to the base of your exiting root at L5, and this is the end of the discectomy, and you can see using an interlaminar approach from the bottom to the top, and this is the whole root which you can see, which is free, and the whole base was covered with disc. It was made in 22 or 24 disc fragments that we removed that day, and as you move your scope, what you can see is you're looking at the exiting traversing route, and you can see at the at the 3 o'clock position in the traversing route. We also went inside the traversing route, and this is the amount of disc fragment that was removed. And you can see a post-operative MRI showing complete removal of the disc fragment. So something like this, I will suggest the interlaminar approach is best. Again, if you have to do bony work, if you have to do decompression, especially when you have a central stenosis, when you want to decompress the central part of the, again, except for the foraminal work, interlaminar approach makes it much more easy to do the job. These are some of the slides I have taken from Dr. Datar, because I think his slides were the best, and I told him I will use it for some of my previous talk. So so this is very, very important to understand that how the transfemoral approach works. I won't go into the details of the transfemoral anatomy because it has been very, very well covered from the previous speaker. But this is a paramount. For me, it was a surprise. I never understood the transfemoral anatomy unless I started doing this surgery. So if you're coming from a background like me or some of the other colleagues who have been open or tubular surgeon and then venture into endoscopy, please read about it. It is a different anatomy. As Tarun was telling, it is a different way to look at the spine, something which we have never done before. So please venture into it. And this I'll just skip because it has already been covered. But understand this: the transfemoral anatomy is dictated by the anatomy of an individual patient. So it is very, very important. Unlike interlaminar, I say, transfemoral, you really need to plan it first. And that is the crux of it. So you need to understand the size of the patient. You need to understand what is the area you're covering. And you have to consider the iliac crest, like the way my previous speakers were talking. And considering everything, you have to plan a surgery, and it is a targeted surgery. You have to hit the bullseye, which is the pathology, and that is where the fun of becoming an transfemoral endoscopic surgeon begins. And understand, as you navigate the transfemoral anatomy, again, this is the slide, thanks Dr. Datar, things change, the perception change, the anatomy change. So understand these, keep these slides in front of you, understand where you are, because there will be times when you will be completely lost in a transfemoral anatomy. So if you understand where you are, it is very, very easy to get the job done. Again, if you are doing a L2-3 level compared to L4-5 level, it is, in fact, if you want to reach a central disc somewhere here, it is much more easy to do it as L2-3 level, because your transfemoral anatomy is the two sides are much closer. But look at this slide. If you are doing at L4-5 level and you want to land somewhere here, it might be bit challenging. You maybe need to work on the bone. You take out the bone and then only you can angle it. So these are some of things you should understand. There's slide just to make you think. It is impossible to teach you everything. Either you join Dr. Datar's course to learn everything, but the idea here is not to teach you everything in one go, but to make you aware how things change. So if you are targeting, this is just to make you understand how you can target and what you cannot target. So you want to target something here, it is almost impossible for a transfemoral approach to do it. Something like this, maybe expert can do it. This is the easiest thing to do through a transfemoral approach, which is extraforaminal disc. So these are just to make you understand how these things work, what you should keep in mind. Now, the easiest thing which you can do with a transfemoral approach is the extraforaminal disc. There is no better way to do an extraforaminal disc than to do it through a transfemoral approach. So this is a patient, 30-year male, presented with L4 radiculopathy due to L4-5 extraforaminal disc. And this is how he walks into my OR. He has a list, and he had a specific radiculopathy due to a due to a extraforaminal disc. And as you know, this is how the disc is. You can see it's a L4-5 disc, which is sort of going up, and this is where it is. And we this is the classical, inter transferal approach. This is how you go and you target it. Understand, most of the time, if you see, what happens is the pathology itself will protect you. So what happens if you see the root will sort of pushed out from the anatomy, and it sort of the first thing which you will see in these cases is the disc, which you will find out. But be careful, it could be the other way around. Sometime then the disc could be pushed in some other direction as well, and it could be coming in your view. So that is how it is. But most, and this is what, if you target it right, the first thing you will see is a disc. Once you have removed quite a significant amount of disc, and that is the time you start seeing the root, which will sort of will be here. In this case, you will see as we go ahead, the root will be this was very thick, edematous, and angry looking root, which is how you see normally. And you make sure that you remove everything, and then you complete the job. Again, something like this is where I prefer a transforaminal approach, a high central disc, which is, this case was, I think, L1, L2, and it is again because of the anatomy, L2, 3, sorry, because the anatomy itself, it is very, very difficult to do anything for these cases. If you want to do internal, it is equally difficult. A transforaminal approach, if you can do it, that is one of the best way, because the anatomy helps you to do the job done. You land almost in the center of the disc, because that is how the anatomy at the higher level of the spine is. And all you need to do is make sure that you go there, you take out the disc fragment, and you make sure that your dura is free, and that is what is being done here. And this is the disc fragment which will come out, and I'll just show you we have a post-operative MRI, and this is the easiest way to take care of this central disc, which is very, very difficult if you plan it anywhere now, any other way. Even if you see, this is a case of discitis. If you look at this, where the pathology is, it is almost posterior to the body. So anything, if you want to do a posterior approach or anything, it is very, very difficult to reach to the problem. One of the best things you can again do, and which we prefer for these cases, it is a transforaminal approach, because you will exactly land somewhere here. You can take out you can take the samples, you can decompress the dura, and sometimes what we have done is even we have gone ahead and add some bone grafts to it, and this is where it is. So this is how this is, of course, we have the advantage of having interoperability. We took out the samples, we took out the pathology, we decompressed the dura, and we sort of filled the whole area under navigation with a bone graft. And this is the gene expert which came out to be positive for tuberculosis. So for me, anything out of ordinary, anything extraordinary, anything which won't solve my problem with my regular approach, that is where the transforaminal approach comes into picture. Again, this is a young patient with a osteophyte growing inside, and she was very young, 22, 23 years old, and always you can fuse them, but if you really want to save the disc level, you want to give them mobility, again what we did is we went with the transforaminal approach. We used navigation to birth the osteophyte, and we got the job done. Something like this, again, this is a hard calcified disc at D12 L1 level. These are the nightmare cases if you want to do it, and it is not easy no matter which approach you use. But I think in these cases, again, if you understand and can do the transforaminal approach, they are one of the best ways to do it. So this is an endoscopic burn. You can, if you target it right, you can burn the whole osteophyte. And this is after, once you have burned this is, so mostly what you see now is the demarcation between dura and the disc. The calcified disc, not everything is normally calcified. The part of it is calcified. Once you have to drill out the calcified part, you can really see the demarcation between dura and the disc. And the end, this is how it looks like. You have taken down all the calcified discs, you have taken down the discs that were compressing, and this is the flutter of the dura, which you can see. So basically these cases were just to show you that although the regular work and the routine work for me is interlaminar, but when you have in situations which are difficult or different to approach at a higher level, that is where I go for the transferal approach. If you, as we were discussing, if you look at the learning curve between the two approaches, the learning curve for transferal approach was found to be steep, but was easy to learn. But when it came to interlaminar, the learning curve is flat, but it is difficult to master. So interlaminar approach is easy to start with, but you really want to master it, it takes much longer time compared to compared to transferal approach. Because one of the problem with interlaminar approach, it is a highly mobile system which you are using. So you really need to understand how to control it and how to make best out of it. If you look at the complication and limitation of the endoscopic spine surgery, we all know that the learning curve is substantial. I don't believe in this statement because the problem is not the learning curve is substantial. The problem is most of us were never exposed to this approach to start with. Tomorrow, once you have start having these approaches during a basic training when you're starting in your medical college, I don't think the learning curve is any different from any other approach. The other problem with this is there is cost. The cost itself is a big factor. But with the Indian companies coming in and the basic set now is becoming cheaper day and day, and I think most of us will be able to afford one system at least. The radiation is always a problem, but if you see as you grow in any technique, you become better with it. For interlaminar, I don't think radiation is much of a worry. Transfemoral approaches, if you are good, you can really reach the disc level or the pathology within 3 or 4 shoots, and that is where we are. Still, I don't think there is a contraindication for endoscopic approach. It all depends upon your skill set. Someone like Dr. Datar or Dr. Lokhande, I think they will be able to solve anything, almost 90%, 95% of pathology, if they feel it can be tackled transformal or interlaminar approach. But you have to understand what is your skill set, how much you can do it, and that is how you should go about it. If you want to drink a soup with a fork, it is very difficult. And if you want to eat a noodle with a spoon, again, it is a nightmare. But this is what you need. You need a spoon and a fork to do most of your job. So I think if you want to become an endoscopic surgeon, you should be good with both interlaminar and transfemoral approach. One approach is good for one pathology, but the other approach could be equally good or easy for another pathology. And believe me, all the limits exist only in the mind. And it is only in the mind that they can be overcome. So it's all about how much you can overcome these limits. And that is where we are today, just to help you understand how to go about it and make your life easy for it. Thank you so much.
Thanks, Ayush. That was a very insightful talk. I think it cleared out a lot of doubts regarding what kind of approach to be taken. I think we will take questions also on the chat, so please feel free to ask questions on the chat, and one of the faculty members will be happy to answer your questions on the chat.
So guys, anything you have, it is better to ask now. What we'll try to do is for this thing, for the cadaveric, we'll try to keep as much as possible hands-on so that we give you maximum time. So let me ask a few things. Sambhav, how much percentage-wise is your interlaminar job compared to transfemoral? Because I'm asking those who do both on a regular basis.
So I think almost 70 to 80% of my endoscopic journey has been interlaminar, and 20% roughly would be around transforaminal. I usually reserve my transforaminal for all the extraforaminal and foraminal discs, but most of my paracentral discs L4-5, L5S1, which are the most common levels we usually operate at, are usually interlaminar. L3-4, L2-3, which is a huge central disc. Now even slowly we venture into even cauda equinas as well. Cauda equina syndromes where we are doing transforaminal approach for L3-4, L2-3 huge central discs. And I think it's a brilliant technique because you're not doing any laminar removal, no phlegm removal, just going in from the side and removing that piece of fragment which is compressing the cauda equina. So in general, it's roughly around 80 to 20%, 80% interlaminar and 20% transforaminal.
What about Dr. Dattar? Where will you put your work in some sort of percentage?
Yeah, I mean, today it would be, I agree with Sambhav that it is about 80% interlaminar and about 20% transforaminal. But again, a few indications from transforaminal, which were not exactly indications, because we do see a lot of multifocal pathologies. We see combination of lateral recess stenosis with foraminal stenosis and an extraforaminal disc herniation. So complex pathologies still would want interlaminar, though transforaminal can be performed in these cases. But interlaminar is a better option because then you can come over the top and actually take care of all these three pathologies. So for me, it is predominantly interlaminar, but yeah, transforaminal still has a big role to play. Especially in cases of revision cases, in cases where there are upper lumbar disc problems or foraminal stenosis, pure foraminal stenosis, discitis. So it's about 80-20, I would say.
So I think Gazwan, I will try to contact Dr. Datta. Are you ready with your talk timing?
Yeah, I'm ready with my talk.
Yeah. So we'll go ahead with you, and you cannot have a better mentor or speaker than the Dr. Girish Datta, who doesn't need any introduction in endoscopic spine surgery, and to do justice to the topic, which is revision, the role of endoscopy in revision spine surgery, and it is a fascinating topic, and how in cases where you don't want to venture into, there are a lot of complication, risk of dural tear, how endoscopy can make your life easy. Over to you, Dr. Datta.
Yeah, thanks a lot, Ayush. I would first take this opportunity to thank ASSI and the team Mumbai for organizing this wonderful Congress. And the concept of having online lectures before we actually venture into the cadaver lab is actually a very good idea, which I'm also trying to pick up for most of my workshops. This gives you a lot of background. It also gives the delegates a good chance that we can give them a lot of hands-on. Okay, I'm sharing my screen now. Is my screen visible?
You can see your screen. Please go ahead.
Okay. Revision surgery, well, has always been a complex thing, even for open surgeries and for multiple minimally invasive options that we have. So here I'm going to talk about revision surgeries, which we have been able to do it since the last about 6 years with interlaminar surgeries and also with transforaminal surgeries. I'm just sharing an insight on what this things. So when we are looking at a surgery for revision, there are some technical requirements that we look. And these are, one is, the first important thing is we need an excellent visualization of the pathanatomy. We should be able to control bleeding with multiple options and modes that we have. Ability to dissect, so we should have maneuverability with the endoscope and the instruments. Ability to remove bone, because we need to have small tools, small instruments, small kerosene rongers. Ability to perform discectomy, decompression, and fusion, because this could be a requirement. So when you have just a recurrent disc, or then probably or recurrent disc, you need to do just a discectomy. For stenosis, you need decompression. And for instability, in a case of revision, you will require a fusion. Now, we also need to have an ability to manage our complications. And the commonest of them is a dural injury during our redo cases because of the scarring that happens after the surgery. Third, and the most important point is that we need to perform the surgery in the presence of implants. Most of the times there are pedicle screws and the rods which are placed. So other techniques, it would be difficult. So you need to operate in presence of implants. And over all about this, you need your technique to be minimally invasive. So let's see, I'm taking a representative case here, just for the sake of understanding. So this was an 80 years female, history of pain in the right buttock and the right lower limb, with mild bilateral paracentral pain for about 3 months, and the left limb pain for 3 months. Then pain increased since last 8 days, was unable to walk for 3 days. She has a history of laminectomy, which was performed from L3 to S1 about 8 years back. Neurology was right SLR 40 degrees, right EHL 0, right ankle dorsiflexor 4, tingling in the right ankle and foot, patchy sensory loss in both limbs. And on the dynamic, standing dynamic X-rays, there was no evidence of instability. Now, I have put down the axial cuts of all the 3 levels which have been operated, that is 3, 4, 4, 5, and 5S1. Now, you see a predominant involvement on the right side at L4, 5, and L5S1. So there are 2 options that we were thinking, whether to go ahead and fuse her up. But considering the fact that her age, the quality of bone, the amount of pain that she has, and most important, doesn't have predominant back pain. She has more of leg pain. So we decided to go ahead and to do a single stage bilateral, single stage decompression at L4-5 and L5S1 on the right side. Now, if you see her X-rays, there are some signs of instability, that is vacuum sign, at practically all the levels that that's seen on the X-rays. But again, sticking to our plan, we decided to do a L4-5 and L5S1 right-sided full endoscopic decompression. So if you see, the most important tactical plan in most of the cases of revision is going to be that you land at the medial pedicular line, unlike you land midway between the midline and the medial pedicular line in a regular case. So the idea behind it is to hug the bone all the time during the surgery. So you identify the pedicle and go along the medial wall of the pedicle, dissecting scar tissue from the bone. It is extremely easy to dissect the scar tissue from the bone rather than trying to figure out where the neurological structures are in a scar. So both the levels were done as at a single setting, L4-5 and L5S1. So what are the surgical steps that we follow when we are doing a revision surgery? First is the docking, which is the most important thing. So identifying the medial pedicular line and on the caudal pedicle, clearing the bone and the soft tissues. There's a lot of scar that lies on the bone itself and the part of the pedicle and the caudal lamina. So that needs to go away before you actually find the edge of the bone and edge of the pedicle. Dissecting the scar to identify the medial facet. So that is going to be the inferior articular process, because the inferior articular process may be hidden, the superior may be hidden underneath the inferior. So the inferior has to be first trimmed for you to identify it, because the superior articular process could be part of the pathology. Trimming of the facet, that is the IAP initially and then the SAP. Removal of the ligamentum flavum after you have detached it from the medial wall of the superior articular process. Dissecting the neural structures and retracting it medially so that you can have a free space to perform your discectomy if required, or if you just remove the facet, then it is only the part of the stenosis that you are handling. Discectomy and RF modulation, definitely important, because there are bleeders. And second thing, you want to shrink in tissues on the ventral aspect of the spinal canal. So first is the docking and dissecting. These are small video clips which I will explain. So this is the initial view on interlaminar on the right side. This is at L5S1. So I'm just taking a representative case here, L5S1. So this is scar tissue which is overlying the pedicle. You can start seeing the scar tissue typical in appearance. So I'm using a plasma wand to dissect the scar tissue from the bone so that I can see the bone very clearly, which is going to be the dorsal most aspect of the pedicle. I'm seeing the edge of the bone here and trying to dissect it with a blunt dissector. At no point of time I'm using sharp instruments here, because I don't know the anatomy till I reach my level. So gradually dissecting. It is extremely easy to dissect on the medial wall of the pedicle. So we keep the medial wall of the pedicle completely hugged, so that at every point we follow just the bone. Once the bone is identified, the first thing that we would do is start trimming the inferior articular process. So use the smallest kerison that you have and gradually start trimming bone under vision. So most of the times in full endoscopy, you don't see much bleeders, though you may encounter, and which you can very easily stop, but you are able to see a very nice clear field because of the constant irrigation. So you first trim the inferior articular process from cranial to caudal. You may alternatively use a hooded burr, small size, 3 mm is available, 4 mm is available, 5 mm is also available for you to remove bone. Then the next point is going to be identifying the superior articular process. So you take off the ligamentum flavum, which is the superficial part, if there is something left behind, and gradually start trimming the medial margin of the superior articular process, which you can see I'm doing here. You may encounter bleeding here coming from the Batson plexus, which you can very easily coagulate with the radiofrequency or with the plasma. So once the entire margin of the SAP along with the part of the caudal lamina is removed, it is easy to remove the ligamentum flavum, but you need to understand that the ligamentum flavum could be adhered to the dura. So bits and pieces of removal of ligamentum flavum, try and move your instrument underneath the ligamentum flavum, cranial and caudal, so that you dissect out any adhesions if there are present. Now you'll be able to only dissect out weak adhesions, not strong adhesions. You have to, if there is a strong adhesion, you need to cut an island and leave it the way it is rather than taking it off. Retraction of the neural structures again need to reach the lateral most aspect of the neurological structures with the blunt dissector gradually and sweep the entire neurological structures from the floor. So you need to use a kind of dissector from cranial to caudal and gradually dissect the neurological structures. You may use a kind of a retractor, which is a semicircular retractor, for you to gradually retract and dissect the neurological structures from the surrounding area. Then is going to be the discectomy. Keeping the retractor in place, you can start doing a discectomy. Here, this was a disc herniation and some scar tissue, both. So there was an element of stenosis coming from the SAP, which was also removed. And you can see doing a discectomy here. So remove the disc from all the angles. See that the traversing route is completely free. Sometimes with this kind of a technique, a more central herniation would be difficult. And in that situation, I would resort to a transforaminal surgery for revision. So once I do a discectomy, I use a plasma bond or a radiofrequency to shrink all the tissues so that you have adequate space there. Nevertheless, this is also going to scar again. So, but do a thorough decompression there and finally confirm it with nicely pulsating neurological structures. You can see the nice pulsations from the neurological structures after the decompression is completed. Here is a second is this is a representative case. Again, we had an L4-5 recurrent disc herniation here after the primary surgery was done about a couple of years back. And then we could do it with an interlaminar decompression in this case. Such simple cases are very easy because you can directly sweep it to find your target pathology and remove it. There are more complex wherein there are chances of dural tears where adhesions are very strong. And here a combination of things would be required. This is again a representative case where you have a disc herniation, but over a period of time, the patient has developed instability. So if you see the axial cut of the MRI, there is evidence of lateral recess stenosis, which we were able to take off and do a fusion, which is a transfacetal fusion that you can do. So going through the facet rather than going through the scar tissue and augmenting it with bone graft. Thanks a lot for your patient listening. I hope this has given a small insight on how revision surgeries can be performed with endoscopy. We've been successful in doing more than 70 now revision surgeries, and we have had our bit of complications. That was about 6 cases of dural injuries, which we could easily manage endoscopic. So none of the cases we had to open up for managing our own complications. Thanks a lot.
So, thank you, Dr. Datar, for excellent talk. So uh, when you revise your own endoscopic surgery, do you find it any challenging? Do you find, or it is much easy to do compared to when you have revised the open surgery?
Uh, no, endoscopic surgeries are easy to revise, I would say, because the planes are very well maintained. If you're looking at transforaminal revision, then it is much easier because we don't find much scarring. For interlaminar approach, the scarring is very limited. So you may always go cranial and caudal, identify the normal margin of the bone and the soft tissue, and from there start your dissection downwards towards the scar. So transforaminal is the easiest revision you can do. Interlaminar is a little bit difficult than transforaminal.
And do you sort of change your approaches? Like if you possible, if you have gone interlaminar and you can do the revision through transforaminal, does it make more sense?
It does, but then the pathology should be in such a way that it is accessible transforaminally. So we don't try to overkill that. If there is a pathology which I cannot take it off with transforaminal, I would resort to interlaminar. But yes, if an alternative approach is available and it is accessible, then definitely yes.
Datar sir,
Yeah, please,
Yeah.
Tarun, please.
sir, I have a case today. 20 years back, open spine surgery has been done at L4, L5 level, and patient is having instability. So I'm planning to do transforaminal and do percutaneous screw fixation. I do interlaminar also, but I am worrying that there should be no dural tear, or landing is also difficult because the surgeon has taken out the lamina extensively.
So the first thing that I want to ask you is there a need for decompression or is it just the stabilization?
Just a stabilization.
So if it is just a stabilization, you can very well do it transforaminal, there is not a problem. But if you are looking for decompression, and if your decompression is going to be possible only with interlaminar surgery, I think no matter how much bone has been taken, nobody will take off pedicle. So hug the pedicle, caudal pedicle, be around the caudal pedicle, go along the medial wall of the caudal pedicle, it will lead you to the pathology.
Before we move on, there is a question for you, Dr. Datta. In cases of previous discectomy and recurrent disc herniation from the same side, how to tackle the adhesions between nerve root and the disc fragment?
You really don't do any kind of dissection with the neurological structures. You just sweep the whole thing along with the scar from the floor of the spinal canal. If you try to dissect it, there is a high chance of neurological injury. So it is always better to create a kind of a dissection plane between the bone and the scar tissue or the neural tissue, whatever it is, and then go to the floor of the spinal canal and then gradually sweep the whole thing to from the floor medial onwards, where the pathology will be evident.
Okay, so before we move on to Gazwan, we have Dr. Vishal Kundani. Vishal doesn't need any introduction. He is our dynamic organizing secretary. And look at the plethora of, the workshop, the lectures, and the way it is planned. And no one is better to welcome you rather than Vishal. So let me give some time to Vishal to just talk about how.
Not much ado. Thank you, Ayush, for a wonderful and lovely morning that you have created for me already. I'm already ecstatic to hear these words. But let me take this opportunity on behalf of ASICON 2024 to welcome you all lovely faculty members on this awesome Sunday, and all the delegates who have spared time for this wishful learning session on endoscopy. Mind you, endoscopy, the way it is growing, I'm really worried whether if I don't get onto this bus, I will already have missed the spine bandwagon. And I really wish that you all catch up this bandwagon so well that you all come up as established endoscopic surgeons after the course is over. And on behalf of ASICON 2024, I wish you all a wishful learning. I welcome you all to the Maximum City of Mumbai. Dr. Girish Datta, Dr. Malcolm, Dr. Gazwan, Pradeep, Sambhav, Ayush, Pramod, Arun. I really thank you all for sparing time and making this a session that people will really cherish upon in future to come. Mind you, delegates, this is only the beginning. Picture abhi baki hai, because endoscopy is not only restricted to these few hours of cadaveric pre-phase 1 and during the cadaver. We have had endoscopic sessions by WFSC, by WES, by ESILS, and many other sessions in the global sessions. There is lots of endoscopy happening during the ASICON conference also, including the hands-on sawbone workshops during the conference on endoscopic armamentarium also. There are endoscopic sessions. There are almost 8 hours of academics of endoscopy happening during the conference also, apart from what you are learning today and during the cadaveric workshop. And I'm really, really hopeful that you all enjoy and cherish the moments of endoscopic learning during this conference in ASICON 2024. With this, without taking much time, I welcome you all to the Maximum City of Mumbai to enjoy the Maximum ASICON 2024. Welcome you all. Thank you again.
Thank you, Vishal, and we'll all look forward to having a academic feast and party and many more things. I know you cannot disappoint us, and that is the faith we have in you. And moving ahead, let me invite a good friend and a colleague from Iraq, Dr. Ghazwan. Ghazwan will be talking about, what are the challenges and pitfalls in endoscopic spine surgery. So, welcome, Ghazwan. We'll see you soon in Mumbai. But let's hear over to you for your.
Thank you, Ayush. Thank you, ASICON, and good morning. And sorry for misunderstood. I calculate the difference in the time as a prospective, not a retrospective. So let me share my my screen. Now it's okay, right?
I cannot see your screen. I can just see you. Please share it.
Now,
yeah,
I think I
sharing. Yeah.
Now it's okay, right? So
now we can see your screen. Yeah, please go ahead, Ghazwan.
Yeah.
So I think there is a delay in your screen. So go slowly. So that is there is a few seconds delay. Okay. So go a bit slow when you change the screen. I think you should be fine. Okay.
Okay. So the talk will be the challenges and the pitfall of the endoscopic spine surgery. I like to deliver such talk as I'm a beginner, considering when I'm standing among the big hero that's available today. These are my disclosure, nothing related. So I think that's when I started to do endoscopic spine surgery, I think the step will be like that, but sometime it will. I felt in the beginning of my journey when I faced an infection of the first 2 cases that I did, which is unusual in the, let's say, in the career of endoscopic spine surgery. So after that, I'm trying to solve the problem by alternative way. For me, today, endoscopic spine surgery, let's say, is rapidly growing. And if we return back to the history, I think that
please mute all the. I muted. Guys, please make sure you don't disturb the talk. Keep yourself muted. Ghazwan, sorry for it. Go ahead.
Yeah, okay. So when we talk about let's say Kodak company, which was the leader of the photography before, and the BlackBerry was leader of the iPhone, of the phone company before, I think that's the open surgery will join them, and which is disappear when we compare right now of the endoscopic spine surgery. This is a message to the guys who resist to do still open surgery and resist the endoscopic spine surgery. I think that's the endoscopic spine surgery is rapidly growing, as I mentioned before. I put this talk because when previously I put on LinkedIn the 10 conflict of the UBE, which get lots of impression, more than about 12,000. So I started to think about, let's say, the common question that's highlighted whenever any guy who want to start with the endoscopic spine surgery. And these are the question, and I will start to solve it or answer it from my perspective. First of all, why endoscopic spine surgery? If we see this diagram, which is talking about the number of the literature comparing per year, and you see that last few years there are there are lots of paper talking about endoscopic spine surgery in the last year. This is up to 2020, and here in the last 3 years we have more and more. So the literature attracted by the endoscopic spine surgery in the last year. Second, I took this let's say publication about again in the same answer about why endoscopic spine surgery. They conclude that it improves the minimal invasive approach for various spine pathology with a greater benefit to the patient with a similar or better than outcome. This is a very important, because for me, if I get the similar outcome to the compared to the previous technique, which I used to use, so I will join the endoscopic spine surgery, because in the long vision, in the long term, there will be more innovative technique, as my friend now presented cases for the revision surgery. So and before they started only to do endoscopic spine surgery for simple disc, but right now endoscopic spine surgery, they can do everything. Second, in this second problem, that's, let's say, for me also, I think that endoscopic spine surgery solve some problem that we faced before, as in this case, when there is a foraminal stenosis, we face struggle to solve this problem before by going either interlaminar or paramedian approaches to solve it. Still face this problem, but I think that transforaminal approach is an ideal approach for this case. Again, we published a chapter book about the endoscopic spine surgery, as it will be a gold standard technique in the spine pathology, and we review all the progression and the innovation that's happened in it. So when it comes to the how to overcome the learning curve, and I think that there are lots of talk, lots of let's say publication about it, but I have a personal opinion about that, because what we let's say think about the learning curve, and I think that to start with, we have lots of online resources, cadaver courses, and the backup surgeon. These are the three cornerstone when we start to do any new technique. But again, we published a chapter of book about how to learn and how to overcome the learning curve by giving up these 12 steps to learn, which is published in this book. And it's important that we have to, when it's come to the learning curve, it's we have to think about it's a graphic about the definition, that's it's a graphic representation of the relationship between the proficient and the experience. This is from Wikipedia, but in the endoscopic spine surgery, what does it mean actually? It's mean less complication, less time, automation, efficiency, or other things. And another important point, there are many factors that depend or determine the learning curve. It's depend on the surgeon experience, how experienced you are, and what you are coming from. You are coming from open surgery to endoscope, or you are coming from MIS or tubular in the microscopic surgery to the let's say to endoscopic spine surgery. And also whether you are orthopedic or neuro. This is concerning about the UBE technique. Although the inventor of the UBE are a neurosurgeon, but we are orthopedic, we are more familiar with the triangulation when it's come to with the UBE as we trained before in the knee surgery. And another important point about the training center, how many cases per week perform this center when you are going to train there? If you are going to train in Korea and some center in India, which their cases are frequent, so the learning curve for you will be better than when you are going to center that's doing only a few cases per week. And another important factor is a backup surgeon, which is for me work. And I think that's till now I train 3 surgeons to do endoscopic spine surgery, they didn't attend any course before by using this backup surgery. And another point, that's the pathology, whether to start with the disc, stenosis, a number of the levels. So if you choose a number of cases like discectomy, simple discectomy, the operation will be easier than doing the revision or the stenosis cases. Which case to start? This is another question. That's for me, that's 5S1 posterolateral fresh disc will be an ideal case for interlaminar cases, whether 3-4, let's say posterolateral case will be disc will be ideal for let's say transforaminal. And when it's come Y5S1, as we see here, this is the interlaminar spaces in the L5S1, and this is for the 4-5. So you will have a big window to start and to do discectomy without any bony intervention and without any bony work that you will need in the 5S1 disc. And another point, that's if we let's say we need to review the case in details. This is very important in my locality, because in many cases that's we see just let's say an MRI on paper, which is not so clear. But I used to use the CD and to plan my cases in details on the CD. And also I saw that, well, I don't know whether you agree with me or not, that's when we see the patient with like this case, which is a Bertolletti syndrome or let's say transition vertebra, I start to rethink again about choosing these cases as initial case, because I face some problem with such cases by still complaining from back pain, although I discussed with them about it. That's the surgery will be just for radiculopathy. So I don't recommend to use such cases as initial cases, because you will feel like, let's say, less confident about the outcome of the surgery. And what about the calcified disc? This is again when we talk about with the open surgeon, that's, you said that calcified disc is a limitation for endoscopic spine surgery. I don't know why, because we can still do the let's say the discectomy for calcified disc. This is a very interesting paper from my friend and mentor Ervan, that he described that for some cases to do an indirect decompression by lateral recess and foramectomy and leaving the disc alone, which is reliable and could be applied also for the endoscopic spine surgery. But when it's come with some instruments that's available right now, we can do a discectomy for calcified disc, and also we can, let's say, use some instruments which is developed by the other guys like this to deal with the calcified disc. So I don't think that there will be a limitation when mentioned the calcified disc in the endoscopic spine. Fifth point, that's how can we decrease the rate of the recurrence? Actually, from, let's say, from my perspective and the collective data, I have about 1.5 to 2% of the recurrence rate till now, although I'm happy, but let's wait to see. But I learned that I don't want to do an overdo, because in the beginning I started to do lots of work in the laminar, in the discectomy side, creating large hole, which is, I think that this is one of the recipe to do to make the disc to recur. And another point, that's in some cases I started to do sequestrectomy only without jeopardizing the nucleus and creating a large hole in the disc space in order to encourage for the let's say recurrence rate. This is one of the recurrent disc that I did as my friend Jayesh presented the cases, which is I think it's reliable and could be done and let's say by the endoscope again. And one of the important point that I learned and applied in my cases, that in every case I do lateral recess decompression and foraminectomy in order to create more space, which is I think that's the message that I compared with the Ervin let's say paper and some mentors that when we discuss with them to decrease the recurrence rate. Another point, that's how can we have a good grip. I think that's when you have a short scope like this one, and you can hold it much more comfortable when you compare it with the other long scope. This is I feel that's it's much more easier to use it, and when we compared with the longest scope. And another point, that's when we say it's enough. And this is the question that I think that it's the same applied for the open surgery. And I think that if you review your case in advance, if you have a full idea about the disc, its position and its extent before the surgery on the MRI, you will have a full knowledge to go directly to the disc and remove it. And when I have a good disc, which is large disc, I think that's I go just for sequestrectomy. And when I have a simple bulge, I think that's I will do more on the disc space rather than in the canal. So this is a very important point. Another point, that's how can we decrease the postoperative dystocia? Because in my initial cases, I faced some cases to let's say to complaining from the paresthesia post-op, which is resolved within 1 to 2 weeks. So I learned that don't manipulate more the roots when you enter to the let's say to the canal. Start to make more space by doing lateral recess decompression foraminectomy before targeting the disc space, and also avoid the central disc by doing through the interlaminar space, because I did one cases and she developed Coda equine syndrome post-op and then resolved within 4 weeks, because I didn't have enough experience to do it by let's say transforaminal, and the patient complaining from also calcified disc at that time. And also when some companies they produce a root retractor rather than introducing the whole sleeve in the canal to retract the nerve root, which is a smart idea for me. That's to decrease the let's say the injury or traction to the nerve root. And another important point, be careful to control the epidural bleeding, because whenever you have let's say a fully bloody field, it is very difficult to control it and also to identify the tissue that's available. So be careful. How to control the bleeding, which is again another dilemma and another problem that's facing for anyone who is started to think about endoscopy. Yeah. So I think that's
Ghazwan, you are muted by mistake. Please unmute yourself.
Okay. So
Yeah.
so I think that's you have to control the mean pressure and the pump pressure in the first time, and we used to close the working channel and make let's say the field clear and identify the source of the bleeding and tackle it by the RF to control it. And sometimes when you see the oozing from the bone itself, this is happening in some cases of stenosis or UBE cases. So I think that you can use the wax just to control it. And I will end it with the last question. That's what about the MRI? Still there is let's say a disc space. Still, there is a disc when you use the MRI. This is my, let's say, daily question, not only from the patient, but from the other colleague that say, oh, you didn't do anything because the MRI post-op, let's say, it's still there is a disc. I have a couple of, let's say, answer. That's why we do need MRI actually. Do you do MRI as a regular? I don't think so. But what about the clinical symptom? The patient has complete resolution of the symptoms, but some guys, they still consist them that you have to take an MRI. And another advantage of the endoscopic spine surgery, you have to recording that's make sure that you did your job. But if we go to the literature and to see that this is the MRI of the post-operative patient with the open discectomy, and this is the MRI of the post-operative patient with endoscopic spine surgery. And you can imagine this is the difference. So anyone who insists to take an MRI, let's take the MRI for the open surgery and to see the damage of the muscle. And again, that's the evidence support that is still some cases, up to 1/3 of cases, they still have some remnant on MRI, but they let's say need a time up to 3 months in order to make the difference. And the post-operative MRI does not affect the surgical outcome. This is another talk that they conclude that the MRI finding within 1 week, up to 2/3 of cases, there will be a residual. So they don't depend on it; they depend on the clinical symptom. And this is my end of the talk. And thank you for listening. And thank you.
Okay, thank you, Gazwan. You can unshare your screen, please. Yeah, and you know, it is, you know, the reason we gave you this talk, because it's not easy to overcome the learning curve and everything, and not only you, but even in India, it's not something that everyone is as privileged and sitting in a big center. So, you know, you have started this in your country. Not only you have started, but you have been training fellows, and they are pretty well trained. So my question is, what was the most difficult part of overcoming this curve, at least in your situation and in your experience? How did you go about it?
You know, Ayush, as I mentioned before, the backup surgeon for me is the critical. So when I, as I told you, when I started the first 2 cases, I did the transforaminal approach for that time. You know, in every step that you do, you don't have an answer. So I started the cases. So this is, the landing will be okay or not. So the discectomy is enough or not. So I think that's the best way, as we discussed with you before. I started to do the endoscopic interlaminar approaches, and I put tubular, let's say, as a backup. So I discussed with the patient that I will do for you microscopic surgery. So I try to do interlaminar. In the first few cases, I shifted toward the tubular, and in every shift, I start to rethink again and put a feedback, take a feedback, and discuss with some guys and some friends that I have. So in the second case, I start to overcome the first struggles, and then to do it again. I discuss with the patient to do just the tubular. The fourth patient, that's he ended up with the endoscopic discectomy, and he was happy at that time. And although the decision was between, let's say, tubular microscope to endoscope is advantage for him, but it was unplanned from his perspective. So whenever in the first 4 cases, I shift to tubular. So in any case that I shift, I record all the data, all the struggle that I faced, and I start to discuss with the mentor in order to not to face it again. This is what I did actually.
Yeah, so it's a great way. So you step one step at a time as you go, and you move on from one step to other. That is how you climb the ladder, and then you become someone like Malcolm or Girish Datta, and that is where we are. So before we introduce the stalwarts, we have a question on the chat box, and the question asks, how many cases or when do you do the CT for your discectomy cases to find about the calcified disc? I think the other way to put it is, how do you diagnose a calcified disc on your preoperative scan, and when do you go about the CT? I think that is a better question. Maybe Dr. Malcolm, when do you suspect a patient has a calcified disc? What are the telltale signs clinically on MRI, or do you get a CT scan for all your cases?
Every patient above 40, please do a CT.
Okay. Dr. Datta, do you agree with the statement?
Yeah, by and large, yes. Chronicity is one thing that you would look at, how long the symptoms have been. Second thing is, if it is an upper lumbar pathology, definitely get a CT. So lower lumbar pathology is not very common to have a calcified disc. But by and large, you are there. So it really doesn't matter whether it is calcified or not. You're still going to remove it.
Yeah. So I think that is where you have, I believe the calcified discs are slightly more black on T1. It is very difficult to, judge it, but that is my perception. And they are long standing. You'll find it more in the upper level compared to lower level. And if you have any doubt, it is better to do a CT. But if you are there, you have to get the job done and go away with it. That is my take. Anyone has anything different to add? Sambhav or maybe Pradeep, please go ahead.
No, on this point, I think everyone's mentioned CT we would only do in the cases which have been explained right now by Dr. Malcolm and Dr. Girish. I just had one more point to Dr. Gazwan's presentation with regards to the learning curve. Now, what happens is when you're starting endoscopy, you have a pressure on yourself as well as a surgeon because you're trying to do it the first time. And I feel that when you've sold endoscopy to the patient, the pressure increases because you want to try and complete that surgery endoscopically. And you, as a surgeon in the start, are under more pressure. So I would say initially, in your at least 10-15 cases minimum, don't try to sell the endoscopy, sell the discectomy. So irrespective of what challenges you face intra-op, you can always open it. You can do a micro discectomy, you can do a tubular discectomy, and in the end, the patient is having a leg, he has no pain in the leg. When you sell endoscopy and you want to finish that surgery through endoscopy and you do face some challenges, unnecessary as a surgeon, as a starter, you are under more pressure. So that would just be my one comment, that don't sell endoscopy in the start, sell discectomy.
Yeah, this is what I meant actually. I start to do endoscopic surgery, and I sell the patient tubular surgery because in the first few cases I shift from from endoscopic to tubular. I'm totally agree with you.
Okay, so hang on, Gazwan. We'll have later your video talk. So next, who can talk better than Dr. Malcolm about UBE? And we will like to know from the horse's mouth if there is some truth to all the hype that UB is doing. So over to you, Dr. Malcolm. Let's see what and how you can give us insight into the world of UB.
Boss, I tell you, UB is a hype. Ask question. Arey, ek minute, huh? Just 1 second, I don't know.
Yeah, no problem. Take your time, because there is a lot of now. What Dr. Malcolm has done is made everyone a UB surgeon. So I have a lot of requests from UB faculty. Oh, I do UB, So it is. We guys will be the last men standing with the full endoscopy. Every second person is a UB faculty today. Thanks to Dr. Malcolm.
Sir, Acha, I'm really happy. I'm proud. But actually, I'll tell you, I agree with you that UP is genuinely a hype. I thoroughly agree.
That's why we brought you. So our idea is to make the delegates understand. And that is the whole idea of this. We cannot teach you endoscopy in 2-3 hours, but at least you understand what is happening. And these are the guys who have really done it, and they are the best to tell you. So over to you, Dr. Malcolm, to take over the UB talk.
Thank you, sir. Insight into the world of UB. It is a hype. I believe it's a hype. But now, when we are going to talk about UB, let's talk about the whole spectrum of UB. So we'll start with cervical spine. I'll be very fast. I'll try and stick to my 15-minute schedule. Here you see me doing a burring of the lateral masses. This is the lower lateral mass. And as you open up the edge of the myelin, you can see a disc herniation over there. And you can pull it out very nicely using a 2mm grasper. Then you can use a regular disc punch. You can see the pedicular corner over there. You can see the exiting and traversing root both coming into your views as the fragment is moving out. And eventually the axilla will fall down and grasp the pedicle itself. So in cervical, I use it for discectomies. Now, I also use it in patients with myelopathy. Here you have a 67-year-old patient with cervical myeloradiculopathy in both hands involving multiple roots. And patient was not even able to hold a spoon. He was not able to walk unassisted. And you can see here that we have done 6 side, 3 on either side. We have done foraminotomies. We have a floating tip technique. We have done hemilaminectomies on contralateral sides. And this is the 18-month follow-up. You can see that at 4-5, there is a fascial fusion that has occurred. There is no progression of the K line. As a matter of fact, this is healed. Patient is absolutely normal. He's come to me for a job now. I'm surprised, but that's the story. Now, even in the cervical spine, people used to initially say you can't go over the top and you can't go over the top decompression. But last year when I was in France, I presented this video and I'm playing it again. And see me going over the top into the contralateral foramen. So you can do an over the top. There is a technique to it, but once you master it, it becomes very easy to do an over the top decompression, even in the cervical spine. And this is keeping the phlegm intact. Now I'm doing an en bloc phlebectomy to remove the phlegm, and then I will again go back to that foramen to do the finishing touches. So even in the cervical spine, UB is a viable alternative. I mean, it's hype, I agree, but it does a lot. So here we are stripping away the phlegm in an en bloc manner. It is badly plastered. So from the edge, and now going again across the phlegm to complete that foraminotomy, because I felt there was some phlegm, some little more edge over there that needed to be cut and opened up. So you can appreciate that we are going over the cervical cord and we are doing a contralateral foraminotomy. क्या होता है आयुष, everybody keeps showing foraminotomy ipsilaterally, तो हमको थोड़ा contralateral तो दिखाना पड़ेगा ना? What do you say, Girish bhai?
It's a great, master is always something to learn from the master. That's why we call you. That's why I don't talk about you.
Sir. Anyway, I'll just, it's just about to get over. No, sorry, we jump to the next video. Okay, let's just play the next video. Here you can see that we have done one set of incisions and we are doing 2 foramens opening up and we are doing the hemilaminectomy. Now we are going down and we are removing the lamina on both sides. So you can see that from C3, we have come down to C5 by removing only the C4 hemilaminectomy. Now this helps to decompress the myelopathic cord very nicely. Here you can see a hook on the contralateral foramen from the ipsilateral side. Now we also do cervical ACDFs, but here we switch to monoportal. And this is a video showing me doing a cervical complete ACDF using even the scope even the cage has been put using a scope. There is no opening up of the patient, no using of any retractors. And this is the cage going in. I use a hemi-cut cannula to slide in the cage from below the dura, below the esophagus. In the thoracic spine, yes, UB has a nice role to play. I'm going to play a video which shows you doing thoracic OLF. I always prefer to go contralaterally, thin out the bone on the opposite side, then use a small dissector to enter inside, flip it, make the hole a little larger so that I can put in a 1mm, 2mm kerrison, and then gradually open up the thoracic OLF. So Now, when you come to the lumbar spine, UB gives you a great advantage. It gives you the ability to do what is called as para-UB. Para-UB is much more comfortable than with a monoportal scope. You have a wider scope of manipulation over here. So I'm playing here, and you can see I've already done the SAP osteotomy. I've gone into the axilla from outside the spinal column after cutting the SAP. And here I'm removing an up-migrated fragment through the axilla. I've been perhaps the first surgeon in the world to do this, and now I'm presenting this work in France this year. So through para-UB, we keep removing these fragments. So at L1, 2, L2, 3, L3, 4, where you don't want to go up, you don't want to do some vast amount of, laminectomy or laminotomy, weaken the pars. Just cutting a small tip of the SAP gives you the advantage of landing right on the axilla and going up. Dear friends, and welcome to another edition of How Do We Do It. Today we are going to discuss the safe extraction of a large non-migrated disc. As you can see, I'm working in the superior edge of the inferior lamina and the SAP junction. I prefer to remove 2-3 millimeters of bone to expose the traversing root as it enters the canal. I then place a small dissector to enter the subligamentous zone, and then using my disc punch as a retractor, turn, rotate, and grab a fragment. Slowly pull it, keeping in mind that there is no movement or pull on the dural edge. This way, I do not need a root retractor. I do not need the services of an assistant. And I can do this job very comfortably. I prefer to go from the shoulder of the root rather than the axilla in such cases. And you can see how nicely the axilla has got decompressed when I remove the disc from the shoulder. The reason is that in a tight axilla, as you try to enter, you may crush the nerve root further. Now I'm removing both the fragments in a very nice manner, trying to pull out some more of this attached adherent subligamentous tissue attached to the PLL. If nothing else works, use a hook. A hook is a very beautiful thing, and you can see how nicely the whole axilla is now decompressed.
Dr. Malcolm, we can't hear you when you're commenting.
Hello, can you hear me now?
Yes, we can now.
1 minute, can you hear me?
Yes, we can.
I'm going to go underneath it. I'm going to see on the vertebral surface. I'm going to make sure I have left nothing behind, and bang, one more small piece comes out. So, probing the subligamentous spaces of great vital essence. Removing thick subligamentous. What I tried to show you in that video is that when there's a very large down-migrated herniation in the axilla, we are very urged to go in the axilla and pull out the fragment. But at that time, we don't forget that if it's a root at risk, you're crushing that root against the pedicle. So it's better to go for a shoulder extraction of such a thing. And when you remove multiple fragments, you realize, you saw in the video, how the entire axilla had become free and the root had come close to the main dural surface. You can go underneath the dura, you can walk across the dura, you can go to the opposite medial pedicular line, you can do a lot of work in UB. Now I'm planning to play the next video where you can see an up-migrated herniation, but it is up-migrated above the root, it's not below the root. So it's an extraforaminal disc with an up-migration. And I have again done an SOP osteotomy. I've done a para-UB here. You can see the cut surface of the SAP over there. I'm removing the disc, and now I'm clearing the space in the axilla. And finally, what you will see is a hook, which is outside and underneath the root, outside where that fragment was. We have extracted that fragment without touching the lamina, without touching the flavum, without exposing the cord, nothing, just para-UB. This is my own patient. My own patient comes back to me after about 10 years with collapse. See this foramen, it's a horrible foramen. Trying to put in a large scope over there would bring immense pressure on the root. So again, my obvious choice was to go for a para-UB, which is what I did. You can see me landing on the pars, coming down the pedicular corner and opening up the superior corner after doing an SAP osteotomy and freeing the nerve root. So you can completely free a nerve root. You can redo this surgery. Para-UB can also be redone. So that is the take-home message in that. Next. Now, here again, I'm going to show you one more para-UB video where there is severe foraminal stenosis, severe. You can see the SAP here. You can see the IAP here. You can see the transverse process here. Everything is plastered. We are doing a para-UB. We are opening up the entire canal. We are doing an osteotomy of the SAP right now. See how I'm flipping the piece of the SAP out. I'm bringing it outside the spinal column. I'm exposing the nerve root. I'm going up in the axilla, and then I'm extracting a disc. So you can see this disc was inside the root. The one that I showed before was above and outside the root. But both were extraforaminal discs. Central decompressions, yes. Here you see this patient over here. He's got a unilateral one-sided, very tight foramen. I go inside, I find a very hard disc. I undercut on my side. I've done a switching of portals. I've gone on the opposite side of the patient. I've undercut, freed the exiting nerve root. You can see the postoperative CT scan, but all this has been done from within. So when you have a central stenosis, when you have a central pathology, and you still want to explore, do all that and open up the SAP, you can do it from within. So it's an ipsilateral switching portal technique for a hard disc. Here, I have both foramens closed with central stenosis. So I have to open up both foramens. One I have to do contralaterally, one I have to do ipsilaterally. And I have to decompress the foramen and the cord. So see what we are doing. We have gone extraflavally. This whole thing is extraflaval. I've gone into the contralateral foramen. I've done an osteotomy over there. I'm pulling in this fragment beautifully inside. Now I'm doing my ipsilateral decompression. So I can open up both the foramens. I can open up the flavum. I can see both the nerve roots that are exiting, both that are traversing, all four nerve roots very cleanly, keeping entire laminas intact. That is the key point. With other forms of surgery, you tend to be vertical. So you tend to do a little extra bone cutting, which here you can go sublaminar over the flavum into the contralateral foramen without even touching the laminar edge. Now, for L5S1 pathologies, foraminal and extraforaminal pathologies, I feel UB gives a great advantage. What you see here is the coracotransverse ligament. This is a band-like ligament, which is part of the iliolumbar complex, which crushes the exiting nerve root. So I've cut the sacral ala. I'm cutting the anterior edge of the sacral ala. I am freeing the nerve root as it enters the pelvis. So I've come down to the Bertolottis. You can see on one side, the L5 transverse process with all cartilage, hard. I'm not able to even get a bite in there. I'm not able to go there, but I'm able to go towards the sacral side. So I'm going there and I'm freeing it. And what you see below is the huge L5 nerve root. Now here you see me landing directly on the axilla, on the pars. I've triangulated on the pars. And I've done the surgery. So I've freed the nerve root in such a tight Bertolottis where there's hardly a 1 millimeter or 2 millimeters by 2 millimeters gap. So this is the advantage without doing maximum amount of bone work. Here we have a patient with bony stenosis of L5S1 foramen, extraforaminal disc, and a Bertolottis. I have 3 pathologies to attend to. I'm not sure which is causing the massive or all are contributing to the whole thing. So I want a happy patient at the end of the surgery. So what do? You can see the bony stenosis. You can see the thickened facet there. And even in the CT, you can see the extraforaminal disc. See the window. The window is so small. You can see the Bertolottis over there. Now, here I've gone in on the S1 pedicle. I've gone by the side of the root. I'm cutting the pedicle. I'm opening up the bony stenosis. So from outside, I'm opening up the L5 foramen completely. The L5S1 foramen is being opened. I'm climbing up on the root. So by the side, I've started cutting from the side of the S1, going up on the root, going till the traversing root, opening up the entire foramen until I see the fat of the traversing root also. Securing the entire L5 nerve root, then cutting the sacroiliac anterior edge again once, going deep, moving everything to the side, because the L5 nerve root is so large that to approach it from the shoulder side is literally impossible. But here you see me climbing up on the root now, freeing the root from below the transverse process and the superior pedicular corner. So I'm making sure that there is no adhesion to the root. Now the root is bulging. Now I'm cutting the sacroiliac side to get access to the disc. I have a herniation there to attend to, and I have a Bertolotti's to release. So here I'm pulling the root cranially. I've come from by the side of the sacral side. Now I'll be perforating here to remove the fragment. So first, initially, I don't get the fragment, but slowly the whole fragment gets mobilized, and we have a huge fragment coming out. So you clear out the disc, you treated the Bertolotti's, and you treated the foraminal stenosis. All three could be done by para-UB. For L5S1, foraminal, extraforaminal discs, traditionally we've been keeping TLIF as a backup or a safety surgery. But with para-UB, especially for L5S1, life becomes very easy. Fusion. Fusion has been one of the bugbears of our times, but I feel that fusion now is very easy, very safe. I have developed a special technique, or what I call it as an extra-flaval fusion. Here you see the end plates prepared, the graft is inside, dura is not exposed, it's an X-lif, and it's an XT-lif. So I'm coming right out in the foramen, secure the exiting nerve root, put in the cage. After I put in the cage, I go ahead and do the phlebotomy. The phlebotomy is the last 5 minutes of the procedure. Because by and large, once you put in the cage, the phlegm separates on its own. The zone of separation is very easy, and you can go ahead and do the phlebotomy within minutes. But keeping the dura in, keeping the phlegm in place means I can be a one-handed jack. I can put in my cage with one hand very peacefully with the scope in the other. Now, why the XT-lif? Why the XT-lif? Because many times I have come across a plastered nerve root right out at the superior articular process outer surface. So I'm going to play this video, and you can see how badly this root is plastered. See the cut surface of the SAP. Now I'm trying to expose the discal surface, and I'm trying to push away the root. To push away the root, I have to first secure the root. So I'm climbing up on the root, clearing the root, and now I'm removing an up-migrated fragment from there first. And then I will be doing the T-lif surgery. So I've secured a plastered root, shifted it away, put in a cage, removed the up-migrated fragments, and done a fusion. I think that is a comprehensible way of saying that I can do a good job. See this image. This image is of a patient who had a previous laminectomy, has come back to me after 30 years with a listhesis, pain, wanted a surgery, done it beautifully by a para-UB approach once again, removing the facet from outside to inside. I straightway land up in the Camden's triangle. The cord shifts away. I don't need to do any stripping, burring, pushing, nothing. So it becomes so easy to put in a cage, flip a cage, make it horizontal, put it across the midline and jack it up. Take home message, yes, UP is all hype. UB uses expensive instruments? No. It uses a 30,000 rupees Chinese scope. It uses a Saraswati ka 90,000 ka burr. It uses Abbas Bhai ka Mactronis ka 60,000 ka pump. It uses all your simple spine instruments. I don't require setups worth crores of rupees. UB is very difficult to adapt to. Yes, I agree. I mean, 8-10 cases that I think you're on your way. If you have the courage to learn it and learn it. UB is all hype. It cannot do all the surgeries that forms of endoscopy can do. I think other forms of endoscopy maybe do more than what UB does. I think UB does less.
Dr. Lokhande, do you agree that you can do all the surgery through UB? What is your take,
मैं बोल रहा हूँ other
I
form
think
more than what I do. मैं उल्टा बोल रहा हूँ. I'm saying कि UB does less
No,
than.
no, I understand. I'm just asking. No, you told. Now let's Dr. Lokhande tell what he has to do. What is your take? What do you feel?
I think both are different techniques. I do both of them. There is nothing. But if you are aware of both the techniques, then you can understand the finer details of how one tech there is a marginal difference. It's not a major difference, but the difference is definitely there. And if you look at the minimally invasiveness, like recently I was for the AO Spine Asia Pacific Conference. We had a workshop in Bangkok, and I met one of the Korean surgeons there. So he has compared the open tube surgeries with 40 UB post decompressions, and these were all revision surgeries. Like previously 40 cases of UB surgeries were done and 40 cases of open surgeries were done, and what he found that the muscle trauma or the scarring or the epidural scarring which was seen in tube surgeries was lesser as compared to UB surgery. This was even astonishing to me, but that is what his inference is, I think, and he'll be publishing in next few months. But we had a very long discussion on that, and this was really astonishing. So I understand that definitely it is there, and it is a step between tube and full endoscopy. But there are certain marginal areas where tube endoscopy full endoscopy definitely scores, especially the thoracic spine and the transformal approach which you get with it.
Ayush, can I have a comment?
Go on.
Please, Dr. Bank.
I have no arguments with anybody. I have no discussions with anybody, to be very honest. I do what I do. I think I'm happy with what I do. And everybody has their choices. Like I said, it's a big world. UB is dangerous. Yes, it's hype. UB is not really dangerous. It's a very comfortable form of endoscopy. It is a minimally accessed surgery. That is the only one thing that I agree with Pramod on. It's a minimally accessed surgery, but it's not a minimally. It's a maximal spine surgery. That is the difference. The access may be small. Access may be 7 millimeters or 2 cuts of 7 millimeters. Doesn't really matter, brother. What matters is what you can maximally achieve inside and what you can achieve. Sublaminar decompressions. So many things which I feel that UB has a much greater advantage on. But then everyone has their perspectives. All I can tell you about surgery is that surgery is something that should be easily reproducible by everyone, not by a world-class genius like Pramod Lokhande. It doesn't matter. It may be very comfortable in his hands, but not so in very other people's hands. UB is something that is very close to the heart of every spine surgeon because he's been brought up that way when he has done open spine surgeries. He's very comfortable with that anatomy. He's very comfortable with free hand movements. So I think UB overall complements a surgeon's development, and that is why we see the world shifting towards UB rather than other forms of endoscopy.
So, Sambhav, what about you? Where do you stand? Like, why not you have adopted to UB? What is your... Do you think you can do everything with full endoscopy? Or it's just that you don't have time, too busy to, take on...
I've tried to learn the UB technique as well, because I believe every technique may have some place in spine surgery. Like even open surgery still have a place in spine surgeries. But the thing is, yes, one is that what you've learned to start with. I mean, if I've started with full endoscopic and if I'm able to achieve what I want, which is for me the most important, is the most minimal surgery. So even till date, I feel transforaminal is much more, it's the most minimal surgery possible as compared to an interlaminar approach. So when I see an MRI scan, I always try to see whether I'll be able to approach this transforaminally. Obviously, if my work is 80% interlaminar because of the way the indications which are put across to us. But I think full endoscopy, after seeing UB also, I feel has definitely a better advantage, especially for discectomies. With regards to stenosis, I think UB can be a much faster surgery. because eventually you're removing the same amount of bone, etc. But now what Dr. Pramod has mentioned after his talk with the Korean surgeon, I think let's see what it has to show. One question I have actually is from the delegates' point of view. Now they are seeing interlaminar endoscopy, transforaminal endoscopy, and UBE. What do you think would be possible? Say I want everything on my in my OT. I want UBE, I want full endoscopy, I want the works. What would be a better approach? Doing a UBE and then going into a full endoscopy, or doing a full endoscopy would make a UBE much easier? So, Dr. Malcolm, if you've done both.
So let's bring in Gazwan and then Malcolm, because Gazwan is one who has traveled the full cycle, from open to tubes to endoscopy to now. He's a big fan of Malcolm.
I'm cut away, I think.
Oh, he's cut out. Okay, Dr. Malcolm, take it. I think Gazwan is not audible right now.
Ayush, I started my journey in spine surgery from the
Gazwan, you were not audible, so we just please go ahead now.
spine,
Now it's okay. Okay.
Kefi plating, Luges rods, Harrington rods, then coming to tubulars, then coming to transforaminal. I started doing interlaminar in 2017 with a stenoscope. 2018, I shifted to UB. Last 5 or 6 years, I think I've worked majoritarily in UB. It's not that transforaminal is bad, or it's not that interlaminar is bad. Each surgery, each endoscopy is beautiful in some places. So all my students who come to me, I tell them to learn every form of endoscopy. There is no one complete endoscopy. I do anterior cervical endoscopies.
It's very difficult, sir. You being Dr. Malcolm can have everything, but for a ordinary guy, you're talking about crores of rupees if you include everything together.
That is where I'm trying to tell you, that UB is something that can be. See, if you talk from a delegate's point of view, for a delegate who is from a small town, if he's going to spend 15 lakhs in buying a stenoscope and then buying another transforaminal scope or a normal interlaminar scope for another 6-7 lakhs, and then the setup. My entire UB setup is done in 10 lakhs here.
So, okay, let's have a quick word from Gazwan before we move on. Gazwan, your take.
All my students to operate with a Chinese 30,000 rupee scope. I myself use a Chinese 30,000 rupee scope for about 200, 300 spine surgeries.
Okay, sir. Gazwan, your take, and then we move for the next talk, please.
Yeah, I think that's all the mentioned notes are I'm agree with them. I'm doing now the let's say uniportal, biportal, interlaminar, transforaminal, UBE. As I mentioned, let's say there are some points concerning the learning curve. For me, interlaminar is much more easier than UBE, but like Professor Malcolm said, that's when we are talking about the financially, so UBE it's much more cheaper than compared to uniportal. You can do the surgery with the open instruments. So for me, it's a huge impact. In this year, let's say all the cases with the stenosis, I did the UBE because it's much more easier. And also, I don't need a sophisticated instruments from the endoscopic companies, which is cost lots in my country. So I think that's, to summarize it. My plan is whenever I face a disc, I start to think about let's say uniportal, because interlaminar in my hand about 15 to 20 minutes for disc. So it's less time, and I think that it's less invasive compared to the UBE. But let's say the muscle damage and the soft tissue damage, it's depend not only on the technique, but it's depend on the experience of the surgeon. So if you in your initial cases, you will do more muscle damage compared when you become like Malcolm. And if you are like Jayesh, so you can do the transforaminal, it's much more easier than UBE. I'm totally agree with Malcolm about the paramedial approach of the UB. I did some cases. Actually, for me, it's work because for fertility, for fusion, for extraforaminal disc, I saw it's much advantageous compared to the transforaminal approach because you can see all the field and you can manipulate easy with the basic instruments, while in the transforaminal you might struggle. So to conclude it, that's you have to learn all the new technique, and you have to see yourself where you are and in which technique you will be familiar, and to choose the case according to the preferable approach and the pathology. There are no one technique over the other, but it depends on many factors, on your expertise, on the pathologies, and also on the circumstances that you are working and the setting that you have. Thank you.
Thank you, guys. But Dr. Lokhande, Dr. Malcolm wants to finish. He's in some talk. Is it fine with you?
Ayush, can I have a word?
Yeah, please, Dr. Datta. Okay.
Yeah, there's a nice debate going on at UBE and uniportal endoscopy. I think it is left to the choice of the surgeon. Both are by and large minimal invasive. I mean, you can always say single port is better than two ports and all these things are fine, but I don't think it really makes a huge difference. It is the comfort of the surgeon. One chooses to be a very good batsman, the other chooses to be a very good bowler, the third chooses to be a very good wicket keeper, but they all add to the team. So it's like, what gives you the winning part. So they all are good. Now, as far as the cost of UB instruments is concerned, Malcolm, you are using local made instruments. The same can also be used for uniportal endoscopy. The same burr is required, the same RF is required, the same plasma is required, the same instruments, cutting instruments. You buy Indian or German, really doesn't make a difference. The cost is exactly only the scope that makes the difference. And that is a very small price to pay for its minimal invasiveness. So you should never promote cost to be the main factor for UB. I think it is more of a learning curve than other things.
So, this debate is never ending, and we'll have more of it during the conference, and that's why we sort of try to include everything. So, continuing with it, because Dr. Malcolm is somewhere, we cannot hear you. You are muted. You are muted, Dr. Malcolm.
Hello, one question to you, Ayush. Can you hear me?
Yeah, we can hear you now.
Your railway hospital has a complete setup of uniportal, monoportal, correct?
Yeah.
How much did it cost you?
No, that is a different thing. See, what we have, when you have option to drive Mercedes, BMW, and Ferrari, why not? That is where I am. Okay. So if we have all the options, and that is what you are. If you can, why will you say I'll drive only the Maruti? So you are. So that is where I am. But so if you can have everything, we have 4 scopes. So that is a different ball game altogether. That is not the point. But so idea is to So idea is to let the delegates understand what is the best out of it and let them choose.
I also have 4 transforaminal scopes. I have 6 interlaminar scopes. I have about 30 UB scopes. So that is not the issue. Issue is also not finance. What Girish said is beautiful. And the issue is also not technique. The issue is endoscopy.
So Dr. Malcolm, for the sake of time, let's move on to the talks, and then we will again come back to you.
There is only one. Endoscopy wins.
Yeah, that we all agree.
Malcolm, I'll collect all your uniport, single port scopes and bring it back to Miraj. You don't need it anymore.
So Dr. Malcolm, you want to finish because you are in some talk. So let's stick to the time. Let's finish because I have requested our next speaker, Dr. Lokhande, to take after you. Okay. So please finish your. We will finish the talks for UB and then move on to the user.
Thank you, Dr. Lokhande. I'll start with my share and Bang. Here we are. Where is my talk? Yeah. Introduction to UB. And we move this to the side. And I'm just making it large. Please give me 1 second to start with my talk. So for those of you who want to know what UB is all about, Introduction to Unilateral Biportal Endoscopy by Dr. Malcolm Pesing doesn't cover everything, but it tries to cover the few basics that I want to put across to you. So we go to UB. What is UB? It is a surgery that is under irrigation with wide access to both sides of the neural tube. It uses an arthroscope, it uses a burr, it uses plasma radio frequency, it uses normal spine instruments, and a few specialized tools. Okay, why? Why? Because it gives you excellent magnification, it gives you all 4 root visualization, unequivocally clear, no compromise on that. It can release central foraminal lateral stenosis, it can do fusion, it's an easy option in migrations of disc. Why this far better version of I use the word far better version of microscopic endoscopic discectomies because you have a freehand approach, better angles to work with. But yes, tubular surgeons who are used to using the tubes beautifully can do an equally good job. So it's not to decry or, put down anybody. That's never the aim of the game. Basic interlaminar decompression starts by keeping close to the midline. You're 2 to 3 centimeters distance on the skin. You're above the disc. You triangulate on the proximal lamina with your scopic portal as well as with your working portal. Now, why I triangulate on the upper lamina is because I am able to strip downwards caudally all the muscle and interlaminar tissues which retract by nature downwards. Because if you study the musculature of the spine, all muscles, all intrinsic muscles of the spine, they start from the transverse process, reach the mammillary process, and then go up to the upper spinous process. So when you cut a tendon, it's like you're retracting the tendon. It falls back, but then it restucks somewhere else. You're not devastating. So you don't cut from down to up, you strip from up to down. So stripping is always craniocaudal. You use a tubular retractor and you create a proper egress channel. Now, triangulation is the key. You're supposed to triangulate your 2 instruments at the spinolaminar junction edge. It's very easy when you put in the tubes and then you put in a scope by the side of it because it just slides down. And the tubes are so huge that they target and they triangulate the scope directly. So your triangulation is no longer a problem. People are scared of triangulation. People thought triangulation is something very great. No, it's not great. It's something very easy. I'm playing a small video now. Please listen to this video.
An explanation on how do I do it for unilateral biportal endoscopy. Biportal means 2 ports. Unilateral means on one side, endoscopy is fine. We start this procedure by targeting the spinolaminar junction. So we'll now focus over here. This is the spinolaminar junction or the point where I would want to land. Now, after having landed on the spinolaminar junction, we're going to be clocks and putting it here. I use a set of serial dilators to dilate my path to the spine. These dilators are all blunt. They will not go through, they will not hurt the spine in any way. But they will land you right on the muscle. Now I'm using a set of serial dilators. I start from 5 millimeters. I go up to 7, 9, 13, 11, and 13. After I go there, I strip with these dilators across the interlaminar. I literally use them like a props. Having done that, assume that this is a scope in my hand. I take the next portal coming from above the pedicle and then targeting the spinal. I'm showing everything to you on your side so that you can appreciate it. So in reality, I'll be doing it on my side, but because there is a bone in between, you won't be able to appreciate it. So I'm showing you this on the contralateral side. Now having targeted here, my scope is on the lamina. When I turn it round, it is able to see below the spinous process. And this is the inverted U spot. This is the inverted U spot. The inverted U is over here. This is from where I start my burring and drilling. Before I do that, I use a plasma one. This is the plasma one. It's a radio frequency one, which helps me to strip all my muscles away from the interlaminar area on the fascial ridge, exposing the fluid. Now, if the interlaminar window is large, you can thin out the fluid with a punch And then with a gentle dissector, you can do a phlebotomy in the interlaminar area, introduce a kerison, and start your surgery. Thank you.
There is no natural space in the spine, so we're dependent on creating space in the spine. So we have to create a fluid reservoir. For that, we use 30 millimeters of mercury pressure of fluid. It floats the paraspinal off. We use radio frequency or plasma to control the bleeders. And we identify the basic laminar edges and the interlaminar space. This was the old technique by which we used to do it, triangulation, and I'm showing you an old technique. Nowadays, I do it with the tube directly. But you can see how the triangulation is occurring over there on the laminar surface. Now I'm going to play a video which shows how we strip.
How do I do it series? Now, what are we doing here? We are using a plasma.
Now I'm stripping and I'm bringing into my view the laminar surface and
we are handling on the lamina.
Spinous process.
Creating some
I will have to
space.
climb up on the spinous process and create space if I want to do a decompression and move to the contralateral side.
And we are identifying the spinal laminar junction. Right now, I'm clearing tissue from the cranial lamina. And as I clear further, I'm going up. And I'm going up to the base of the spinous process. As you can see, this is the inverted U, which is that starting point to control the breathing. Now I'm stripping the high crest, the upper edge.
Now stripping the interlaminar tissues.
I'm stripping away some of the extra flavum tissues.
When I strip away these tissues, the flavum gets exposed.
I'm going to climb up.
Now I'm going up on the spinous process,
Onto the spinous
right to the interspinous ligament.
Separating away the ligament over there. Here I'm
clearing at the base of the spinous process.
The surface of the lamina. So we have established our first.
Now eventually the flavum starts coming in your view.
Here we are in.
After using a burr,
as this is a
I'm
case of
going
stenosis,
at the base of the spinous process, cutting it so that I can go on to the contralateral side. Now I'm in the opposite lateral
more and more of
I'm
the
going
undercut
down.
sublaminar.
That is the facet joint over there.
And that is the lateral recess side. This is the
IAP
where the
lower
IAP is sweeping downwards.
cortical bone.
Lamina is turning into the IAP.
And this is where the IAP is turning around and becoming the lamina is turning into the IAP. I've come to that junction.
We are going without
As I
decompression.
push
Now
in that
we are
junction,
decompressing the lateral side.
you will see that I will be entering the opposite foramen. So now you see the whole lamina on top of you is intact, right from the superior laminar edge in the contralateral foramen. You have retained the entire bony structure of the contralateral lamina. You have not sacrificed bone to reach the axilla or to reach the foramen on the opposite side. So where it comes to doing decompression, this going under the lamina, cutting into the opposite side, clearing up the lateral recess, this is an advantage. And we have done it completely extraflabally. Now I'm going to play one more small video which shows how I do a phlebotomy. Every time you don't need to do bone work, if there's a large bone window, you just use an arthroscopic punch and you thin out the flavum. As you thin out the flavum, you will see punctate hemorrhaging there. That punctate hemorrhaging tells me that the flavum is now thin. Also, you are able to almost see through the flavum. You can realize that the flavum has become very thin. And now the punctate hemorrhaging has started. So I know that in this stenotic foramen, this stenotic canal, I've done a nice phlebotomy. I'm about to enter inside. I'm not stretching out the flavum. I'm not pushing with my scope. There's no pressure there as such. And you can see how the punctate bleeding is increasing. So safely, very safely, I've thinned out this flavum. And now with a gentle dissector, I will walk through and open up the phlegm. No force, no pressure, no nothing needed, no stressing the phlegm, accidentally pushing a scope through. 1 in a million chance, but that also should not happen. So nicely done. Now when I introduce the kerison, I will lift this phlegm, check for the first bite that there is nothing that is adherent over there, and then continue with the rest of the phlebotomy. Lift and cut to avoid dural tears. So as I lift, you can see through the phlegm, you can see my instrument and you can make sure there is nothing over there. So now I can take the punch and I can bite through it. Cut the PLL to expose the phlegm. Now I'm using an RF wand to directly cut the PLL fibers. I'm in the axilla. It's a downward facing wand. It's a curved wand, so there is no risk of transmission of current to the dura or to the axilla or to the root. And then I'm going to use a ball tip hook to manipulate, mobilize, and finally grasp out this large fragment. So I'm able to deliver this fragment very nicely and beautifully. Multiple fragments were there. We removed all of them. And finally, we go around exposing the traversing nerve root. We have exposed the traversing nerve root. This is the immediate post-op CT, which you can see. There's even a gas bubble there. So there is nothing else in the paraspinal muscles there. Now pause and see this bony window. I'm going to pause this so you can have a look at the bony window and tell me how big is the bony window post-op. The bony
We cannot
window.
see the video, Dr. Malcolm. The video has stopped, at least for me.
Yeah, now the video, I paused it to show you the bony window.
Okay, fine.
Can you see this? This is the small bony window that has exposed the traversing nerve root, axilla, as well as removed the fragment.
No,
So
the
we have,
window is paused at the phlegm where we are dissecting the
The
phlegm.
video is still, it's not moving. Still.
It's not moving.
1 minute. Let me just go back and 1 minute. Did you see this?
No, I think you need to reshare or restart it because it is like a still screen. We are looking at a still screen. We are not looking, there's no movement which is happening.
You can replay it. Now is it playing?
No. I think you just.
Oh my God.
You can move to the next slide, maybe just explain it because it is not moving.
Apologies. Then, this was the last slide actually. It was just showing the phlebotomy and extraction of a fragment.
Okay.
Thank you for that. I don't know what's gone wrong. I don't want to waste your time either. But this is the basic procedure of doing the surgery. The stripping, the cleaning, the going to the phlegm, doing a phlebotomy, extracting a fragment. And overall, if you go and see post-op, then the window is very, very, very small. Very lost, magnification things, you're removing a lot of things, but it's not really the case because your thin scope is literally sitting on the disc. So it becomes pretty easy. Thank you for giving me this opportunity, Dr. Ayush. I thank ASICON, I thank everyone, and I especially thank Dr. Pramod Lokhande. Thank you, sir, for chairing and giving me the opportunity.
So thank you so much, and this is not the end of Dr. Malcolm. We'll have him, demonstrate the beautiful technique. And when you have a guy like Dr. Malcolm, no other than Dr. Lokhande is the one who can, match up to his skill set. And so we have the next speaker, again a dynamite and one of the biggest name in endoscopic spine surgery, Dr. Lokhande, who will be talking about the full endoscopic lumbar interbody fusion. Over to you, Dr. Lokhande, and we are sorry that we have to keep you waiting.
No issues. Thank you for the invitation. I'm so happy to be participating in this wonderful event. Good afternoon, all. Just a minute. Am I audible?
We can see your thing, and of course you're audible. No, you're muted and you're muted.
My
Yeah.
topic of yeah.
Yeah.
Can you hear me now?
Go ahead. Now we can hear you. Yeah.
My topic of discussion today is on full endoscopic lumbar interbody fusion. And so all of us know that lumbar fusion surgeries are one of the most commonly performed spinal surgeries right now in the entire world. And the number is increasing because of one of the reasons for that is the increase in the aging population. And we all know that MIS TLIF is right now the present gold standard and has certain advantages over the open conventional TLIF surgeries, which we all know. But it also has its own set of complications. Praveen Mummaneni, in one of his papers, he has honed down to certain complications, and these are 4 in number. The first one is nerve root related complications or neural tears. The second one is end plate violation because of damage to the end plate by the end plate shavers or other interbody tools. Vascular injury here, especially when there is a rupture of the anterior longitudinal ligament, we can injure the great vessels. And lastly, pseudoarthrosis. Either it is because of inadequate disc removal and disc preparation or too little bone graft. And if you neglect the first complication and you look at all the other 3 complications, all these 3 complications can be attributed to poor non-visualized end plate preparation. This is another paper by Chun on lumbar pseudoarthrosis. He has mentioned incidence of pseudoarthrosis after lumbar fusion surgeries is almost up to 35%. And the risk factors for fusion failures are all these. And if you look at the lower 2 ones, the severe osteoporosis and the end plate management, these are the ones which we have to particularly look for. And these are the ones which can contribute to cage subsidence and cage migration. So when we talk about cage subsidence and cage migration, we have to understand that we have to have a very delicate balance while preparing the end plates. The end plate preparation should neither be too aggressive nor it should be too conservative. And the cartilaginous end plate must be removed while preserving the bony end plate. And visualized insertion of the cages can avoid damage to the bony end plates. So these are all the benefits which are offered by full endoscopic disc space preparation. It's a real trump card. It offers direct visualization of the disc space. There is a delicate separation of the cartilage from the bony plate, especially in osteoporotic patients. And the entry annulus is also visualized, which can prevent catastrophic complications. So the indications of full endoscopic lumbar interbody fusion are the same like any other MIS or open TLIF surgeries. And the objective is to achieve adequate decompression, get a good fusion by preparing a good fusion bed and adequate bone grafts, and restore the sagittal alignment of the spine by distraction compression techniques and placing the cage more anteriorly. So there are 3 approach possibilities right now: the trans-cambian approach or the transformal approach, which I call it as the first generation, the interlaminar approach, which is similar to the conventional Harms technique, and the transfacet approach, which I feel is right now the best approach to do fusions with an endoscope. So if you look at trans-cambian approach, it is something which causes indirect decompression like an olive. So whenever there is not much of posterior compression with the hypertrophic flavum or subarticular stenosis, this is the approach which I would prefer to go in. And the rest of the tools can cause direct decompression of the neural structures. So what is transformal approach? I think it is one of the oldest fusion techniques described right in the 1980s. And one of the pioneers in that is Said Usman. And it is a facet sparing technique. It does not cut the bone. It goes through the Camden's triangle, very least invasive, can be performed under local anesthesia, can be done with a very small endoscope, 4 millimeter working channel. And it, as I told you before, it works on the principle of indirect decompression. Personally, I feel that it is more suitable for thoracic spine surgeries or upper lumbar spine surgeries. The indications are a good disc height and soft stenosis. And the poor indications, according to me, which I feel is a central or lateral recess stenosis and a very collapsed disc space because there is a very high chance of injury to the exiting nerve root. So these are the disadvantage: high risk of ENR injury, exiting nerve root injury, especially in a collapse, disc case, severe foramen stenosis. Almost 25 to 30% of the cases may suffer from some kind of neural symptoms post-operatively. And direct neural decompression is not possible with this technique. It is difficult to insert large size cages. If the facet is intact, you cannot insert very large size cages, and you cannot harvest local bone graft. And the best way is to avoid complication is you can use neuromonitoring in such cases. So these are the disadvantages of transfemoral approach. The second generation is the interlaminar approach, which I feel is the conventional original harms approach, which was discussed before, where you go from the interlaminar space. You don't have to cut the entire facet, just make adequate space for the lateral to the traversing nerve root so that the endoscope can be inserted and the cage can be inserted through it. Done under general anesthesia, we usually use a very large endoscope, 5.6 millimeter working channel. And as I told you, the entire facet did not be removed. So according to me, I think it is more suitable for a lower lumbar spine, especially L5S1, where you don't have to cut the entire facet and get away with it. But there is a certain disadvantage because adequate space is not created. There is a chance of traversing nerve root injury in such cases. The transfacet approach, which is something which I prefer to do, it is done under general anesthesia. We use a larger endoscope. You directly land on the facet. The entire facet is removed, both the superior IAP and the SAP, and it can offer both ipsilateral and contralateral decompression. And one of the advantages of this is you can insert a larger size case, so and least chance of neural injury is possible with this technique. So here are a few cases: grade 1 listhesis, mild stenosis, there is bilateral foraminal decompression, and a mobile listhesis. So I've done a facet approach in this case. The first step is always decompression. You land on the facet. This is the facet joint which you can see, and once that is visible, you separate it out from the rest of the things. This is the osteotome being used to cut the bone. You create space. This is the resection of the superior lamina. I keep resecting laterally towards the pars. This is the pars which is being cut with a Carrison punch. You see that I've not used any drill in this case, just to preserve as much bone as possible so that it can be used for bone grafting. So that was the entire facet which was being removed. This is the hypertrophied flavum to visualize the exiting and the traversing nerve root. That's the traversing nerve root. That's the disc space. You just rotate the working channel and there you land directly on the disc space. The second phase is that of end plate preparation. So it is similar to what we do in open surgery. I use an osteotome to cut the annulus, a box-like cut. These are different specialized instruments which I've made, and they can be used to curate the end plates, the cartilaginous end plate of the bony end plates. And this is the anterior margin of the vertebra, where you can see. So everything is done under direct visualization. Special curates, that's the anterior annulus. You can see, just you don't have to take a CM photo for this to identify where you are located. You can just see the difference of the tissue, and you can directly note that we have come close to the anterior annulus. So this is very safe in avoiding damage to the anterior annulus, especially in very in the cases of infections where there is very thin anterior annulus. So these are the specialized instruments which I've made. And the third stage is that of cage insertion. So when we are putting the cage inside, first thing I use is this half cannula, which I put outside the working channel under direct vision. I rotate it so that the traversing nerve root is retracted and kept retracted by this. And then you directly insert the cage under direct visualization. So this is the final placement of the cage, the traversing nerve root and the exiting nerve root on the right side here. So this is how I use an osteotome to resect the lamina and the facet. I use single hand to hold the endoscope, the working channel, and the osteotome, and the right hand to use the hammer. And this is the insertion of the bone grafts in the front of the disc space before I insert the cage. I use a funnel to insert the bone grafts. Placement of the trial disc spacer and final placement of the cages and the screws. So this is the resected pass which has been resected as en bloc while cutting the facet joint. And this is the final incision. Post-operative X-rays, good alignment, good sagittal alignment, and well-placed implants. Another case, grade 1 listed with severe stenosis, bilateral foraminal stenosis there. Again, I've done an interlamina appendix, interlamina endothelium. This is the cutting of the superior lamina till I reach the free edge of the superior flavum. This is the cutting of the inferior lamina. This is the separation of the ligamentum flavum from the opposite side, opposite lamina. I always try to remove it as a single piece en bloc. There's the single piece, and that's the dural sac. There's the traversing nerve root. You can see a disc fragment there, compressing the traversing nerve root, which I've removed. And this is the cut in the annulus. Again, osteotome is used to separate the cartilaginous end plate from the bony end plate under direct vision. So you see there is no direct damage to the bony end plate, and this is especially very useful in osteoporotic patients where if you use very sharp end plate shavers blindly, in that case there is damage to the bony end plate and subsidence of the cages post-operatively. So this is the final well-placed cage which is seen. This is the amount of bone graft which you get from doing the laminotomy and the facetectomy with an osteotome. So you see, I have never used any drill here, and these are the post-operative images. Another case, grade 2 listhesis with rigid central stenosis. The technique is slightly different in this case. My motto in doing endoscopic surgeries, I always like to think like an open surgeon and try to implement the technique by use of an endoscope. So here what I do is I put the opposite screws first, the opposite side screws first. Then I decompress, I do a complete annular release and a complete discectomy so that the listhesis becomes a little bit mobile. Then you insert the connecting rod on the opposite side. Tighten the distal rod first, and then gradually using that reduction screw mechanism, I tighten the proximal screws so that the reduction happens. And many times I use a guide wireless pedicle screw incision like this. So I just use a pedicle probe under image and feel it, and you can directly see it in this video. So that's the the pedicle probe. The ball probe is able to palpate all the walls, so very useful in osteoporotic patients which have fragile pedicle walls. And this is the final insertion of the screws. So advantages of this guide wireless pedicle screw insertion is very less radiation. I can probe for the pedicle walls, for the breach. It avoids the problems of guide wire like migration and bending and that stuff. And you can use conventional open reduction screws. And I feel that it's better in osteoporotic patients. So this is the reduction. This is the insertion of the rod before reduction, then final tightening, which has caused reduction. Then I distract, and then I insert the trial spacer there. And this is again the amount of bone graft which is there, and the cage filled with bone grafts again. And this is the final placement of the cage. You can see that reduction has been completely achieved with a good sagittal alignment. So there's a difference between reduction protocol for spondylolisthesis. For low grade, I always do a decompression first and insert the cage, followed by pedicle screws. Whereas in high grade, after decompression and preparation of the end plate and the disc space, I try to reduce with the use of the reduction mechanism of the MIS screws on the opposite side. Then I insert the cage. I usually avoid inserting the cage before the reduction is achieved because that makes the whole thing very immobile. What about degenerative scoliosis? This is the case of degenerative scoliosis at L23 and L34 with severe subarticular stenosis on the left side. What I've done is I've done a selective interbody fusion at 2 levels. So I'll just skip this video for the lack of time. And this is the insertion of the cages. And these are the post-operative X-rays. You can see that there is a good sagittal and a coronal alignment as compared to the pre-operative cases. So we use the endoscope portal for the insertion of the distal screws. So 6 tab incisions, and we can do a 2-level T-lip. So can this technique be used for degenerative scoliosis deformity correction? Now, right now, presently, the anterior to psoas approach, the Olive approach, is the gold standard for degenerative scoliosis deformity correction, which involves the approach anterior to the psoas. Secondly, we have the X-leaf, which is trans-psoas, and lastly, I think this is something which is new, is the posterior to the psoas approach, is the PTP approach. So the limitations of Olive approach or the ATP approach is we cannot achieve direct neural decompression in this case. A second approach is needed for that. It has got limited indications. Doing it in L5S1 is not everybody's ball game. It is only for the experienced surgeons. And it has got comparatively higher complication rate because there are nerves, peritoneal structures, and vessels lying everywhere, anteriorly. And it is relatively more expensive. Whereas if you look at this transfacet approach, you look at the size of the Cambrian triangle. So what happens once you remove the facet, the size of the Cambrian triangle really becomes very, very big. So it is possible for us to insert larger size cases. So these are the advantages of transfacet approach. A direct neural decompression is possible. It's a single approach. The anatomy is simple. The Cambrian triangle is safe, devoid of all complicated neurovascular structures, and it is faster, and more importantly, it is cheaper. So why ATP if PTP is better? PTP means the true posterior to psoas approach, not the prone trans-psoas approach, which most of the Olive guys do. And the portal is lying there. We just need technological advancements to access it. The technological advancements which we need right now is the better instrument for faster end-plate preparation, because we have to do multi-level cases. Secondly, better fusion devices, expandable cages. Now, these expandable cages, they should not expand only height-wise. They should expand the size-wise also. They should expand in both the directions. And one of the problems with MIS instrumentation, which I feel, is they fail in causing effective compression and distraction. Techniques as compared to the open section. So there has to be some changes in the MIS screws and instrumentation. And we need to find alternatives for autographs for better fusion rate. So limitations of endofusion, I think it's a steep learning curve. It is not recommended right now for high-grade listhesis or severe deformity. The reason is the bony releases are a little bit challenging and more time-consuming. Secondly, the MIS instrumentation is still not perfected, as I told you, to cause effective reduction of high-grade listhesis. Multi-level fixations are again too time-consuming. It is not possible right now to insert very large footprint cases like Olive cages, but we need to modify them, and we are in the process of that. And revision fusion surgeries might be difficult with endoscopic surgeries. So the key point to remember is it is a safe and effective technique. It offers trifold benefits of elimination, magnification, and a clear field of vision. Low surgical footprint and visualized end-plate preparation is something which hallmarks this particular technique. So the less chances of cage subsidence and migration and pseudoarthrosis, especially in osteoporotic patients, which is right now the current challenge in modern spine surgery. And transfacet approach, I think, is the safest, and it allows insertion of large footprint cages as compared to the conventional smaller cages, but not as big as the Olive cages. And probably it may play a role in the management of degenerative scoliosis. Thank you very much.
Thank you, Dr. Lokhande. Always a pleasure listening to you. So, a few questions. You showed that half sort of a sleeve too while you're putting that cage. Is it from Richard Wolff, or you have personally designed it?
So we have made it. We have prepared it ourselves.
Okay. And there is a question in the chat box, and it is the question says that how do you put a 13 or 14 mm cage if you are using a 8 mm portal in a tall disc patient?
Once we put in the half retractor, we remove the endoscope from that side, and we insert the cage percutaneously. but the endoscope is put into the other portal from where the screw goes in, the superior screw goes in, the superior stab incision, which is made for the pedicle screws. So it is observing at an angle, just like, for example, we are converting a monoportal system into a biportal system where the cage goes through a separate incision and the endoscope goes through a separate incision. So, okay, or should I?
That's what, please ask. No problem. Go ahead.
Yeah, actually, I have experience in the fusion, and I use the both technique, the interlaminar and the transfacet. I saw that's the advantages of the transfacet over the interlaminar. First of all, in the sake of time, it required less time actually. And the second important point that you can harvest a good amount of the bone graft that can be used. I use the UBE technique for fusion, not uniportal. But I'm also concerned about the posterior to psoas approach, although it's in their baby steps right now, but it can take let's say advantage. And we can also do what's called hybrid technique. We can put some olive cages and let's say UBE or uniportal endoscope cages in the other let's say level.
So, Dr. Lokhande, when will you, like, after how many cases, for example, will you ask the delegates to venture into something this? Because, this all is not something you start with. So, I feel like a guy who wants to do a endoscopic fusion, what is the right time to start this?
Yeah, it's very individual. I think it's first of all how naturally gifted you are, that matters a lot. Second is how focused you are, like how many, how adamant you are in using this particular technique. So you need to have a lot of experience using interlaminar technique before. So you have to start with L5S1 level. You have to learn how to handle the instruments. Controlling the endoscope, like you said, is the challenge with interlaminar technique. So you need to control. And as you saw that, I was controlling with a single hand. I was controlling the cannula. I was controlling the endoscope. I was holding the osteotome. And this is a very vital, because a little bit slip here and there, and you're directly going to bang on the neural structures, and the spaghettis are going to come out. So all these things need a little bit of experience. You have to do it slowly and stepwise. So start from L5S1, learn to handle the endoscope, then start doing the bony work at L4-5, start drilling the medial margin. Then in between, I think you can stop using the drill and start using an osteotome to cut the medial margin of the facet. So learn how to use an osteotome again at that way. And once you are comfortable with this, when you plan to do your first fusion surgeries, I would suggest that keep the open set ready. And if you are the endoscopic surgeon, you do a decompression and prepare the end plate and wait for some time. If you have stamina, you can take a break, or you can, if you have stamina, you can continue and insert the cage. For the first few cases, maybe you can have somebody else to put in the screws, because I hope it doesn't make you too tired. But as you become more and more experienced, I think the surgical time for a endoscopic fusion is almost the same like what we do for open surgery. Sometimes I think it is faster than open surgery.
Lokhande, can I ask you a question? Your entry point. How do you mark your entry point for a transfacetal? So do you just take your pedicle screw entry point and then just put your scope through that? Or again, if you want to do over the top, does your entry point change at all to give you the access?
Yeah. If it is an over-the-top decompression, if I want to do a contralateral decompression, I take it slightly at the medial margin of the facet joint. But if it is just unilateral, you can just take it bang on the facet, just like how you dock a tube in the tube surgery, directly on the facet. So similarly, you can do that. Once you gather experience, it doesn't matter where your entry point is, because for me now, all I do is just take a single shot, dock on the facet, and you work there. And you can always go on the opposite side by manipulating the endoscope. So it doesn't matter. But comparing it with the pedicle entry point, I would prefer to take the right entry point for the decompression and use that same entry point by manipulating to insert the screws. You understood that the entry point which is taken should not be perfect for the screws. It should be perfect for the decompression. And you can use that same entry point to put the lower screw. Because if you try to take the perfect incision for the lower pedicle screw and you try to insert the endoscope through that, then there is a lot of soft tissues, which are going to prevent you to reach the opposite side. So especially the skin, there is a lot of stretching of the skin and the muscles. So the whole procedure becomes very difficult and tiring.
So, thank you, Dr. Lokhande. It's always a pleasure. And moving ahead, we have Dr. Sambhav, who is my co-convener for the course. And over to you, Sambhav. He will be teaching us how to do a full endoscopic decompression, the tip, tricks, and the pitfall. Sambhav, over to you.
Thanks, Ayush. Just give me a second. Screen is visualized.
You can see your screen.
So I'm going to be talking about full endoscopic decompression in the case of spinal canal stenosis. So we've seen Dr. Lokhande's technique already, and this is just something which I'm doing before doing a fusion. So probably once you do a couple of these decompressions and they're safe in your hands and you mastered the technique over here, then probably we can go and start doing fusions. So again, similar indications. Why full endoscopic is because you can achieve the same amount of decompression what you can do with a tube or in case of open surgeries as well. But the visualization is much better. I believe that the continuous saline irrigation also helps to dissect the planes between your flavum, your dura. The chances of dural tears are much less as compared to tubular or open surgeries. And obviously you leave behind minimal scar, which is also something which the patient loves. But as we see, the pitfalls, one of the biggest pitfalls, as Dr. Malcolm also mentioned, that is the cost of the surgery. So for any endoscopic surgeries, you need specialized scopes, you need different Garrison punches, pen-filled dissectors, you need the RF machine, you need burrs, especially in cases of stenosis and decompression. You have to burr out the lamina, the medial part of the facet. Sometimes over the top you have to burr out the inferior part of the spinous process. So we cannot perform this surgery without having all these instruments on us and in the OT. The positioning remains the same as any endoscopic surgery. So if I am standing on the patient is going to be in prone. If I'm standing on the right side, your monitor and your C-arm come from the opposite side. You can place your RF and burr near the foot end, and your irrigation comes near the head end. In cases of decompression, I do not like to break the table. Usually for discectomies, we break the table in between, but for decompression, I let the patient be in the natural lordotic position, because sometimes you can land up under decompressing if you try and open up the interlaminar space. And I feel that with any minimally invasive surgery, the more obese the patient is, the less the scar is, and the better these endoscopic techniques are. The entry point is similar to your interlaminar endoscopy, where you are going in the interlaminar region. However, I sometimes guide my entry points based on what exactly I have to decompress. So if I have to go over the top as well, so if I'm going from this side and I want to go and decompress the opposite side, I'll end up taking the incision slightly laterally because that gives me a better access. If I take my incision too medial, then I may have to burr out more amount of the spinous process and the base of the spinous process in trying to go the other side. So if I am doing an ipsilateral decompression, then my incision will be more medial, because then my main work is going to be on the ipsilateral side only. Once we've taken the incision, we dock the working dilator. And with the dilator, I think this is a very important instrument, as it guides you exactly where you want to dock. It helps you scoop off all the soft tissue. So when I put in the dilator, and if I want to go into interlaminar space, the first thing is I put the dilator at the junction of the lamina and the facet. Then I feel where the facet is. I feel the superior lamina, the inferior lamina, and the lateral side, the middle edge of the medial facet, and this is exactly where I dock my cannula, just at the junction of the lamina, facet, and the ligamentum flavum. The reason is that once you remove the soft tissue, when you see these three areas, you know exactly where you are. The problem initially with endoscopy can also get that is that you can get lost. Even though you're in a very small area, the soft tissue can be quite a lot. If you don't know exactly where you are going to be, you can end up being laterally to the facet. You can land up sometimes even on the opposite side. So when you're in, especially in a very obese patient, when you put in the cannula, you can land up going on the opposite side of instead of the ipsilateral side with your dilator. So it's important to master the anatomy. It's important to confirm the anatomy once you dock your scope. Once you put in a dilator, then you put your working cannula, which is similar to your discectomy cannula as well. We use the bevel, which is very important for you know uh, moving away the neurovascular structures. For stenosis, I generally end up using a bigger working channel scope. So this is, we use a 5.6 mm working channel scope. Usually for a discectomy, we are using a 4.1 mm working channel scope. But stenosis, a bigger channel generally helps. So you can use bigger instruments, you can use bigger size burrs. So that makes your surgery much faster. The beauty of interlaminar scopy is that it's so you're zooming in, zooming out using the same the one hand, and you have access superiorly, inferiorly, medially, laterally, as the scope is flexible. However, this advantage is also one of the disadvantages of interlaminar, is that it makes the surgery much more difficult to master. Because of the flexibility, you can get lost very easily. You may be at one place and a little bit the scope moves, the cannula moves, and you can end up being in some different place and you can get lost, even though you are just working in a small 8 mm area, but still it is very easy to get lost inside. So once we've put the scope, the surgery is like any surgery. So where we are feeling the lamina, if you dock over here, so once you see your in through a camera, you should be able to appreciate the ridge of the lamina, the middle part of the facet, and medially the spinous process ridge. And here you will find the flavum. So all the soft tissue needs to be cleared. Once the soft tissue is cleared, you find the medial ridge of the medial facet, below which will be the superior facet. With the annular cutter or this forceps, we clear out some soft tissue from here, clear out soft tissue right from the lamina and the spinous process. Once that is done, and then burring is started, the burring starts at the middle part of the facet. You start burring this and then eventually move up onto the lamina. If over the top decompression is also required, then the under process of the spinous process is also burred. And depending on where the stenosis is, sometimes the lower lamina, superior part also needs to be burred. So once this whole burring is done of this area, and that's when you open up the ligamentum flavum. So one challenge during endoscopy surgery is also, as I said, that one is the soft tissue, number two is the bleeding. So the RF is used very religiously. Don't try to pull out tissue which you have not use the RF on, because once the bleeding starts, then everything can get very, very difficult. Once the soft tissue is removed, the important thing is to then feel all the anatomical structures. You want to feel the medial facet, you want to feel where exactly the lamina is, where the inferior lamina is, where the superior lamina is, and you can use your RF probe for the same. This is clearing of the soft tissue which is being done. This initially can take some time, but you have to be patient in the start. Be exactly sure of where you are. So here, as you can see, I can see that this is the facet, this is the flavum medially, and here will be the superior lamina. So I want to see this view. Now I know exactly where I am. I know my medial borders, my lateral border, and that's when you start the burring. Otherwise, you can land up burring much more, which can cause instability in the future. So I'm starting to burr from the medial part of the facet, and then I will be going superiorly towards my lamina. We have different kinds of burrs as well. We have round cutting burr. We have a burr which is a oval burr cutting burr with a lateral hood. And this I'm now burring just the part of the superior and the medial facet below which the superior facet will be, I can appreciate the phloem attachment. And this I'm removing the part of the superior facet. So again, we try and do as much burring as possible before removing the phloem. This we are burring the part of the superior facet now, which is the lateral recess below this, which is where the main compressions are. This is the oval bud with a front and a lateral root. So this protects your neurovascular structures medially and inferiorly. And here I'm trying to now free the phloem from its attachment. So you can remove the phloem piecemeal, you can remove the phloem en bloc. I mean, it's absolutely your choice. However, I would say finish all the bony work before removing the phloem. Also be very wary that you may have a lot of phloem cutting, the phloem adhesion. So we have to be careful that there are no phloem adhesions there, otherwise the chances of dural injuries are higher. Once you've done the ipsilateral side, so there are 2-3 things. We can even go on the opposite side where you can do over the top decompression first and then come down towards the ipsilateral side, or vice versa. So for example, in this situation, we are burning the base of the spinous process. You can go to the opposite side and then you can do ipsilateral decompression. With regards to the bleeding, there are various ways. So as you see here, the minute you remove the bone, sometimes everything can get blurry. So you can use, pumps which increase the pressure of the water flow. Number 2, if there is a lot of bleeding from one spot and you're not able to get there, you can just use a peneplain sector and press that area and just hold it over there for some time, which reduces the bleeding. Number 3 is we have these rubber coverings which you can put on top of the scope, which increases the pressure for some time, which reduces the bleeding. And you can achieve a very good over-the-top decompression endoscopically. As you see, we can go from pedicle to pedicle. We use the flexibility of the scope, and you can go right from inferior to superior part of the dura. Start with a very simple case. Start with a unilateral lateral recess stenosis case, and then eventually you go into more and more difficult cases, like a case of central stenosis here, which is I think something which you should do much later stage in your endoscopic career. You can also start with something like this, which is a unilateral, just a facetal cyst causing significant pain. So you have to just go on one side. The steps remain the same. Bubbling, then removing the ligamentum flavum, freeing the nerve completely. Another beauty of endoscope is that you can rotate the scope, so you can actually look under the lateral recess, which makes life much easier. Once that is done, you can even retract the nerve. You can do a discectomy as well if you wish to. So I would say you start with discectomies. Once you are very well versed with basic discectomies, you go into migrated discs. Then you do a decompression of just lateral recess ipsilaterally. Then you move on to central stenosis. Then you move on to over-the-top decompressions. Don't go into multi-level compressions to start with. Start with a single level. Try and use a bigger scope. It makes your surgery much faster, and you can use much bigger instruments. And always keep spare burrs. Don't start with just one burr. Initially, when I start, I think all of us can vouch, from Dr. Lokhande to Ayush, that we all have broken burrs initially. It is a part of the learning curve. So don't just start with having one burr inside your OT, because you are going to break burrs initially in the start of your decompression career. Locate yourself very well. Be sure where you are. Feel with probe. Use your dissector. Check your C-arms again and again. Dock at the junction of the lamina phloem facet, so you are sure that you are at the right space. You can identify everything. I usually prefer burring first and then decompress, because it makes the surgery much more safer. And try and tell your anesthetist to maintain a lower BP. You can use pumps, pressure pumps for irrigation. You can use diamond burrs, which reduce the bleeding, or you can even use your penfields and press that area and just be patient. It is a very high learning curve. Initially, you can start as a surgeon, you will start feeling tingling and numbness in if you're you have to hold the camera, the scope in your left hand, the whole arm will start becoming numb. But it is something which you just start getting used to. Over time, then you go into multi-level. Instrument cost is one of the pitfalls, but I think Even when you're doing a tubular decompression, the better surgeries with a microscope, and even a good microscope costs you 5 crores. So I don't think that instrument cost is something which we should be thinking about. And breakage of instruments. Initially in your learning curve, again, you will be breaking a lot of instruments. So that is one of the pitfalls I see with endoscopy. But otherwise, overall, it's a beautiful surgery, and you can achieve whatever your end goal is with this surgery as opposed to any minimally invasive surgery. Thank you.
Thank you, Sambhav. Always a pleasure. So my question will be: what is your threshold for multi-level decompression using endoscope? How many levels have you done till now? And is it sort of, does it bother you? Like if you have to do 4 levels, do you think, oh, I'm better off with a tubular open than to do endoscopy?
I mean, see, absolutely. The higher the levels you have to decompress, even if you're doing tubular, is going to take more time because you're docking at every level. You are doing the same as against open one incision exposure at the same time, and you start using your big ronchos and decompress everything. But again, the advantage of endoscopy is that you are also removing minimal bone. You are just removing the pathology. So I call endoscopy as a surgical strike, where you are just removing the pathology and you're saving a lot of normal anatomical structures. So, but yes, up till now I've done a 3 level decompression. Now on I started off doing decompression, which initially took me 1.5 hours. Now on an average, I decompress a level is 45 minutes to an hour. I've done 3 levels, but it was a strenuous day. I will make sure I'm not keeping a second case on the same day and make sure I don't have a packed OPD after that. Because I think more important, it's us mentally, it's our patients' levels. Now, if there is an 86-year-old with multi-level with anesthesia issues, and if I have, the anesthetist says do the fastest surgery possible, you have to weigh advantages. In that patient, I'm going to go open. I'm not even going to put my tubes. But wherever I can, I try to use the endoscopic approach now because I do see a clear advantage. But 3 levels is what I've done maximum. But I don't keep time as a factor when I'm giving my patients option of endoscopic decompression.
Same question to you, Dr. Datta. What is your limit? Like on a busy day, will you still do a 4 level endoscopic decompression, or you feel okay, fine, let's do something different for that?
See, first and foremost thing we need to understand is the pathology at 3 levels plus. So we are talking about targeted surgeries. That means we need to identify the pathology. So in very, very rare scenarios, you would have something beyond 3 levels. So L1 to S1 laminectomy is no more true these days. We need to look into the patient's clinical symptomatology and then go ahead. And if a situation demands, then you can always do it. That is not a problem. But I think by and large, 2 level is the one that we do maximum. I would say more than 80% of the cases, if we are doing multi-level, is 2 level, and 3 level is less than 20%. So if it demands, then yes, but there is no such clear-cut, multi-level, because we do see a lot of bulges, we do stenosis, clear-cut stenosis, but not everything is symptomatic. So identifying the symptomatic primary, secondary, and tertiary level is important rather than, just looking at the MRI and decompressing the whole thing. Really doesn't serve any purpose.
Yeah, completely agree with you. Yeah, it sort of gives you a opportunity to do very, very less and get away with it. So
Exactly.
although you're doing 2, 3 levels, but actually you might not be doing a complete laminectomy decompression at each and every level. And that is the beauty of endoscopy. That is what I also believe in. And staying with Dr. Datta, we will have his step-to-step video on transformal approach. He's one of the masters, and there's no other person who can teach you better than him when it comes to transformal approach. Over to you, Dr. Datta.
Yeah, just a minute. Is my screen visible?
Yeah, we can see. Please go ahead.
Yeah. So I'm talking about the transforaminal surgery, step by step. A little bit of a thing is, though I explain the line markings and how you really put it and what are the technical tips and tricks, that would be better shown on the cadaver. But I'll still try my best to show you how step by step we are doing it. So let me take a representative case here. You can see that this is an engineer with an upper lumbar herniation. So you see a herniation at L23, a large herniation by and large. You can see the axial sections also showing a large herniation. The CT scan is by and large normal. Since it's upper lumbar herniation, I would definitely do a CT scan to identify if there is a ossification or calcification of the bone or the herniation part which is there. So let's dive into how we plan it. So most important thing in any kind of a herniation is to identify what is your skin entry point and what is going to be the docking point in the foramen. That's going to be the most important thing. And the higher up in the lumbar spine you go beyond L3-4, so that means L2-3 and L1-2 and above levels above, a transforaminal surgery is much more better because the interpedicular distances are narrow. So even if you are a little steeper to get inside the foramen and the disc, you're still okay because you immediately reach the opposite side, because your endoscope also has about 30 degrees, 25 to 30 degrees of view. That is the angle of the endoscope. So you have 25 degrees and 30 degrees as manufactured by different companies. So first thing to understand, what is the extent of the herniation is the most important thing. Whether it, how superior, inferior is it migrated, how medial and lateral is it migrated. So you should know what your target is. Where are you going to approach? Second thing is, to plan a level, you should also understand what is the interpedicular distance. Doing a extruded herniation, which is more central in location at L5S1, is extremely difficult, but the same kind of a herniation at L1-2 or L2-3 may be very easy because of the interpedicular distances. So docking point on the annulus is important. One is the skin entry point, that how shallow you can go and how much does a lateralization, the anatomy gives you the flexibility of lateralization, and where are you going to dock in on the annulus. Is the trajectory going to be sufficient to decompress the entire segment is also a second point that needs to be told, answered, or you need to do a primary foraminotomy. Either you do an inside-out foraminotomy or do an outside-in foraminotomy. The choice is left to you and the comfort. So this is important to understand. Where is the target? Where do you start on the skin and where do you dock in the foramen? Whether a primary foraminotomy is required or not required. So depending upon that, you're going to plan your skin entry points. So by and large, the skin entry points, there are 4 skin entry points, 2 based on consistent anatomical landmarks and 2 based on geometrical calculations. So the ones that are based on geometrical calculations is, the depth is measured from the anterior border of the disc to the posterior skin, or from the middle of the disc to the posterior skin. So these are 2 entry points. So whatever you calculate on that, and translate it on the skin, becomes 2 entry points calculated as per geometrical calculations. 2 as per consistent anatomical landmarks are going to be the tip of the spinous process entry. That means you draw a line directly coinciding with the tip of the spinous process on the lateral, or you can draw from the dorsal aspect of the facet joint. Now, the dorsal aspect of the facet joint is a tricky entry because the needle goes underneath the intertransverse ligament and your entire system is very mobile. And this is practically a epidural entry rather than an intradiscal entry. So doing this kind of an entry in upper lumbar pathologies may be extremely difficult because of the proximity of the retroperitoneal space. You need a very good paraspinal musculature which is extended laterally. So 4, 5, 3, 4 and 4, 5, 3, 4 also difficult, but 4, 5 you'll be able to do. And if L5S1 with a shallow iliac crest is also possible. But by and large, in upper lumbar herniations, the other entry points are pretty much good. That means from the anterior border of the disc, or from the center of the disc, or from the tip of the spinous process, are entry points for majority of problems that you see in the lumbar spine. So here in this particular patient, so we always start with what is called as a medial branch block, because essentially what I see is the advantage of a transforamen endoscopy is doing it under local anesthesia, because foramen is again a very favorite site for pathological or congenital anomalous anatomy. So you may have a conjoint root, you may have a lot of things. So I don't prefer any of my cases transforaminally to be done under general anesthesia or regional anesthesia. So I use monitored anesthesia care to augment, because most of the patients who come to us are pretty chronic. We get very few patients who come very, very acute, but they come quite chronic, and there is already a sympathetic recruitment, and this sympathetic recruitment causes sympathetic mediated pain. If you do a medial branch block for the segment before you actually do your endoscopy, perforating the annulus becomes extremely painless, absolutely. And those still have the root completely alive, and that root can still perceive the pain. But annular entry becomes very comfortable for the patient. So we always augment it with medial branch block with a 1% of Xylocard, which is half cc, is more than sufficient to give you a nice block for the medial branch, which causes reduction of the sympathetic mediated pain. Now here in this case, first line that we draw is, first we ensure that the patient is stable on the operating table, prone in position with supported by bolsters, abdomen is free, and the pedicle, the spinous process is well centered between the two pedicles. That means there is no rotation in the spinal segment. Then you don't correct the lordosis or kyphosis, and you maintain it the way it is by just the way it is, especially that is a problem at L5S1s, that you tend to correct the lordosis, but I keep it the way it is. The first line that you draw is connecting the spinous processes, so you draw a straight line. The second line which is drawn, which is parallel to the disc. So normally if the disc is not collapsed, the tip of the spinous process usually coincides with the disc. This is a consistent anatomical landmark. Only when the disc is collapsed, you may have to make small adjustments to be at the level of the disc. The third line is the line that you draw either from the anterior border of the disc or from the middle of the disc, depending upon what point do you choose, and draw. This is also called as the disc inclination line. And from this depth, you measure it till the skin, mark your entry point. Now, I would be happy to do it when you're actually doing it on the cadaver. Then you start with the needle. So infiltrating the skin and the subcutaneous tissue, the Xylocard, 1% Xylocard, and continue injecting inside till you reach the lateral border of the facet. So you touch the bone, give half cc of Xylocard there so as to block the facet capsule, so you don't have inadvertent pain when you're putting in your dilator. After the block is done, then you put in the stylet of the needle, so that the whole, because these are long needles, so 18 gauge needles, so you put in a stylet so that all the local anesthetic that is present in the barrel of the needle is completely put out, and then you enter into the foramen. Now, normally at L5S1s and L4-5, even if the herniation is not very big, you must enter at the medial pedicular line. But if the herniations are larger, you can enter medial to the medial pedicular line, and you are still safe, because the entire thecal sac along with the root is lifted dorsalwards. So you have a more larger space. In fact, the Camden's triangle becomes larger in this patient. So you can go a little more medial if your intention is to decompress something which is more towards the center. So here, since it is an upper herniation, I just go with the mid or the medial pedicular border. Since the herniation is also large, it's more comfortable. But if the herniation is small, it is better to enter at the mid pedicular line above, like L23 and L12 and L4 at the mid pedicular line, because the thecal sac is quite loaded with the neural structures. So I get inside disc. Primarily, the needle is advanced till the midline, and on the lateral, I should be in the posterior 10-15% of the disc, because this is a grade 3 herniation. That means the herniation dorsally is beyond, migrated beyond the facet joint. So I would use complete epidural or just subannular. This is my intention here. So once I'm there, I would always do a chromodiscogram. Two reasons to do it. One is you identify that you can the nucleus, so that it is easy for you to remove everything. And even if you don't do a chromodiscography, at least a discography would be definitely be advantageous to see if there are any connections, pseudo connections with the thecal sac or anything like that. So after the chromodiscogram, I would put in serial dilators over the guide wire till I have reached the annulus. So I put in the serial guide wires and to the largest size available, and then over that a conical dilator which can go. So on the surface of the annulus, you will use sharp hammering with the hammer, taps with the hammer, that you can perforate the annulus to get inside intradiscal. Now, pushing it manually with your hand is not a very good idea, because you do not have a control of how much to push and where to stop. So it is better to hammer it with the hammer so that you go intradiscal. So once you go intradiscal, you can slide your cannula over the conical dilator to reach intradiscal. Now, initially, when you start, it is better to be a little intradiscal, because you are going to land in and there's going to be a bloody field. Go inside completely and then start clearing up your way. And then you can always come out into the epidural space to remove the entire fragment. Now, this is especially true if the herniations are very small. If a herniation is large, by and large, if you take off a little bit of intradiscal, you are going to be in the herniation. Okay, so here, once I have entered inside, I've started removing the part of the herniation here directly. You see some lateral aspect of the lateralmost aspect of the annulus, which is in the foramen. You may choose to partially cut it if it is a small herniation, or you may cut a complete thickness of this part of the annulus in the foramen here, primarily in the lateral recess, I would say, and then start working your way inside. Now, until and unless you see your neurological structures, you would direct the jaw of your rounger towards ventral side, not towards the dorsal side, because everything is obscured by this herniation. So you don't see the neurological structures. So making your way inside, gradually you find the herniation. Now here, if you see the herniations are collagenized, you don't have a staining of the herniation. So collagenized herniations are difficult. One is it is hard, and second thing is it does not get stained well. So you keep on working your way, stopping all the bleeders using your 4 megahertz radio frequency and doing your discectomy step by step. Now, every point of time, if you are in doubt, check your AP and lateral to confirm your position inside and gradually go. So use the 15 degrees or the 25-degree optics of your endoscope to see where your ronger is going and what you are removing, rather than blindly putting your ronger, opening the jaw and holding it. Any point of time you want to probe, use a blunt ball tip probe to understand. Now, again, need to continuously be in communication with the patient. The patient should be awake and aware, answering all your questions. So if you're in a doubt about a structure, whether this is part of the annulus or part of the traversing route, you can always probe it a little bit and ask the patient whether he's perceiving some kind of pain or something like that, which will definitely give you a good idea of where it is. Now, all the remaining herniation, since this was a large herniation in the upper segment, I can still go in the midline, not only in the midline, but to the contralateral side because of the optics of my endoscope. I'm able to see beyond what I can actually reach. So I have to use or maneuver the endoscope in such a way that I'm able to remove the herniation that is there in the ipsilateral side, the midline, and the contralateral side. So the end point of the decompression is going to be here in this situation where the annulus practically completely destroyed because of the annulus, because of the herniation. You'll be able to see the ipsilateral root, the thecal sac, and the contralateral. You see, I've practically reached the medial pedicular border on the contralateral side. So you can do a nucleoplasty by shrinking part of the nucleus which is there, because not everything can be removed. These are all collagenous parts. But by and large, you have to ensure a good decompression of the ventral dura. You can see central dura, you can see contralateral root and the ipsilateral root. Here the annulus is completely destroyed here. So obviously the outcomes over a period of time, a patient is always at a risk of a recurrent herniation here in this case. So this is how you treat your endoscopy. You may choose to put in steroid side if you think there is a lot of inflammation, and if there is no inflammation, then steroid really has no value there. So why do you do this? It's technically easy, because even you can work within the depth, superior visibility, achieve good ventral decompression without even retracting any of these neurological structures, does not violate the facet joint. Especially in upper lumbar herniations where the foramens are larger, you don't need a foraminotomy. But at 4-5 and 5S1, you often require a foraminotomy, where you cut the non-articular part of the superior articular process so that you can get a more dorsal access. Shorter operating times, herniations like this doesn't take more than 25-30 minutes by and large. Patient advantage is it's a single incision, which is a posterior lateral incision, which sutureless. It's a small incision. You just get away without any suture. Minimal to no blood loss. Post-operatively, there is not much pain. Patient may stay overnight if you feel so. Able to return back to his life, active life very soon. Price is comparable to open surgery. It's not very expensive or something like that. Advantages of the technique is no muscle dissection, prevents secondary instability because no stabilizing structure has been disturbed. This is a surgery under local anesthesia with the patient awake and aware. So all old infirm patients not fit for anesthesia can be done. You can also do it by choice in younger patients because the herniation is big and there are advantages to this procedure. So I think I have been able to give you a glimpse of how transforaminal endoscopy is done step by step. But I think the real thing is going to be when we are going to work on the cadaver. Thanks a lot, Ayush.
Thank you so much. And I think this is as complete as possible. And we hopefully we will be able to repeat these talks again for the sake of delegates before we allow them to go with the hands-on cadaveric workshop. So we are already running short of time. So to go on with the lectures, let's call upon Dr. Ghazwan, who will be talking about the step-by-step video interlaminar approach. Ghazwan, you are there? Is Dr. Ghazwan was there? Is there?
Yep.
Yeah, please.
Okay, let me share the screen. Is it shared right now?
You can see. Please go ahead.
Yep. First of all, again, thank you. And it's a great pleasure to be among the heroes of the endoscopic spine surgeon here. These are my talk. And I think that's the first of all, we have to highlight it and do and do nots in the endoscopic spine surgery. From my perspective, I prefer to do the case in the first case in the list in the morning, review the case in details, check the position, make a good relation with the anesthetic team because you need a stable mean pressure. Start with a straightforward case. We all agree about that, and we discuss about it. Backup option in your initial cases, and review your work deliberately. And I don't prefer to do it in a busy day, especially in my initial cases. And don't skip the step. In my initial cases, I skip one lateral X-ray, and I found myself inside the canal directly, and I caused the dural tear at that time. Don't rush. Take your time because the outcome is better than the time. And don't follow your ego. And finally, don't overdo because when you jeopardize the ligamentum, the disc space more, you will face recurrent disc more. So as I mentioned, that's we have to have a good MRI, X-ray, dynamic X-ray, and also full spine X-ray. It's not full spine MRI in some cases, especially in the elderly, to exclude other pathology, and any further investigation when it's needed in special cases. And the position of the patient is very important, as the previous mentioned, because it's can control the bleeding intra-op and also to decrease the time of the surgery. The first case to start with the 4 interlaminar is 5S1. As we know, that's the interlaminar space in the 5S1 is bigger and wider compared to the other cases. And also, you don't need a bony work at that level. This is the entry point for the right side, and you can start it, which is actually compared at the clock 10 o'clock at the right side and 2 o'clock at the left side of the patients. And this is for the right side, and I put that 10 step to do it, and we will review it in details. First of all, draping is very important in order to keep the theater and the OR dry. I'm using that one for gynecology. That's with pouch that's collect the fluid, and we sucker it whenever we need it. And another important point, you have to have a good AP and lateral X-ray, because MIS surgery and the endoscopic spine surgery specifically highly depends on the X-ray, and the landing is one of the key steps in successful surgery. And the second point, that's check the mini pressure with anesthesia before, and also the abdominal pressure, because it will disrupt your work when it's not on optimum level. I recommend that to do the mini pressure in the interlaminar approach about 60, and the less the peak abdominal pressure, the better the outcome that you can face. And the first point, that you have to have a sniper landing, what I call it. When you introduce the dilator, you follow the bony landmark. It started with the spinous process toward the lamina, and then inferiorly that you feel a step, which is that you are in the interlaminar space. And a very important point, that you have to have, let's say, a feeling, and whenever in the initial cases, whenever you feel any struggle, start to take a lateral X-ray, and this is the initial view that you will see in your initial entry point, the fatty and some muscle tissue, and try to remove it, and to let's say to have this view of the let's say ligamentum flavum, which is much clear. And then the next step, you try to clear more the field by using the RF and the cautery, the lateral edges, and you will have a full space that's lined by ligamentum flavum. The way to enter the canal, it's differ in many techniques. Some guys, they are using the punch, while I prefer to use the dissector, as mentioned here, because it gives me more confidence, and it's less risk to damage the underlying tissue. So I started with the dissector, making a hole so the fluid will be push the neural element away, and then after that I started to do it with a Kerrison by introducing to the neural canal, and also widening the space. These are the steps when you go further and removing the ligamentum flavum, and you will enter to the neural canal, and you can visualize easily the neural element. The first structure that you face, I recommend that you put it in your mind. This is the dura, this is not the root, in order till you find the root, because it's very important. although sometimes you enter to the lateral, and the first structure that you will face will be a root, but you have to double check by going medially to see the dura and to identify the root, and then after that manipulate it. Careful handling with the neural element. This is very important by using the dissectors, and also don't press or don't manipulate initially, because as we know that the disc is the disc is already pushing the roots, and the root is in the strangulated or in a very narrow space. So you have to have a good clearance by doing in every cases for the interlaminar. I'm doing the lateral recess decompression, and I'm doing foraminectomy in order to widen the space and give a free space for the roots to be manipulated by the endoscope later on. And also some guys, they say that it's decreased the recurrence rate. It's not only decrease the symptomatic recurrence rate, because the root have a good space for to include some recurrent disc in the future if it's happen. And then you will end up let's say by landing to the disc. There are many options that's available. Some guys, they prefer to use the sleeve, and I have this system that's they have let's say the root retractor, so I can use it and then introduce the instrument, would give me more confidence and less traction to the nerve root, and finally achieving the goal by simply doing the removing this big disc, and you will feel the dopamine surge when you will have such a big disc that you remove it as a one space. And finally, when you remove the disc, try to look for any remnant pieces that could be present, and especially when you have a good review on the MRI pre-operatively, so you can find some missed or let's say migrated piece, you can remove it by hook. And final step that I'm doing, that's I do what's called the nucleoplasty by using the bipolar radio frequency in order to make a shrinkage in the bulged nucleus and give a better view on post-operative MRI. These are the steps that I'm using in my daily life, and to perform the interlaminar as simple as. And thank you for you all.
Thank you, Ghazwan. It is as beautiful as possible. I think the steps sums it up. And any questions anyone has, you are most welcome to ask us right now, or even later. Please, you all of the delegates are there on the delegate group, so you can ask anything which is relevant to this talks, and we will more than happy to get back to you. For the sake of the presentation, we have recorded all the presentations, and we'll try to get it available to you just in case you have missed it out. The next stage will be on 21st, which is the Sunday after the conference. And remember, the workshop is happening is Nair, which is one of the big medical colleges in Mumbai. It has a new lab which we have hired. I hope you will enjoy the experience. We will the cadavers are supposed to be fresh, but we don't know exactly how they will be, but that is what we have promised. It is a operative setup. In the lab is dedicated for this type of cadaveric workshop. It is not a anatomy hall. That is what we have tried to bring it to the table, so you get to experience the best of it. We will be in touch with you, the delegates, on the group which we have created for you. You can reach out to us for anything which is important, any problems or anything. We'll try to solve to the best of our ability, and all the faculty which was here today will be there to help you and to help you learn. And the idea of the cadaveric workshop is we have covered almost all of the theory part of it. We'll again revise the video talks, and then the faculty will demonstrate the step by step. And we will like to give you as much time as possible so that you can do the hands-on workshop. So anything, Sambhav, you want to add to it?
I would just like to add one thing that use now. I think the cadaveric workshop we have 2 weeks, so I would just request the delegates to try and get yourself see as many videos as possible. Dr. Datta, Ayush, they all have videos online. If you just YouTube endoscopic, you will get a lot of videos. So you don't waste time on the cadaver to trying to figure out the anatomy and the technique, etc., because you want maximum hands-on. So just try and orient yourself with as much anatomy and the videos as possible, which will make your cadaveric course more fruitful, I think.
So with this, I think we should call an end to the session. We had a very fruitful discussion. Let me thank upon all the faculty for being there. Most of you stayed till the end. Thank you, Dr. Datar, Pradeep, Gazwan joined us from all the way from Iraq. And of course, Sambhav is always there for anything. And we look forward to having you here in Mumbai. Let's have a beautiful conference and let's have a beautiful cadaveric course when you join us in Mumbai and within almost 10 days. Okay, so I'm looking forward to seeing you all. Let's enjoy our time and let's give it best for the delegates. Thank you everyone.
Thank you, everyone. Thank you.
Thank you for preparation and organization.